There it is. I think it's working now. Okay. Hello, everyone. Welcome. Welcome to those who are participating online. Welcome to those in this room. We're very happy to welcome you today to our pre-Congress session on gender and health economics. So this is a session that we've put together at WHO for those of us working mainly as economists in various areas of health systems. On issues related to gender and not related to gender, and sort of noticing there's a bit of a research gap, a bit of a capacity gap in the areas of gender and health economics. There was an online session convened by IHEA a few months back on this topic, and then we saw the opportunity to put together a pre-Congress session to look at a few different areas. Next. So the session objectives today are under three areas that we're calling learning, sharing, and debating. So there are three sections that we're breaking up this session in. The first of them is a learning session, which is going to be facilitated by Asha George. In this session, the aim is to really present some gender analytical frameworks for addressing and different tools for looking at your research to see how gender responsive it is in the areas of health systems and health economics. The second area that we're going to have is a sharing session. And this session is kind of a deep dive into some of the areas where we've seen or maybe haven't seen so much of the interface of gender and health economics. The three particular areas we're going in these sharing sessions and examples we're sharing are under the areas of health workforce, they're under the areas of health financing, and they're under the areas of sexual and reproductive health services. So we'll do a little bit of a deep dive into these three particular areas and share some of our experience as health economists working in this area, trying to integrate gender. The third and final session is the session that's sort of a debate or discussion session. So given that we see this as an area that has some research that we've seen available, we've seen gaps in other areas, we really want to bring everybody in this room together to talk about their experiences in this area of gender and health economics, where you see the gaps, where you think more energy needs to be spent and really looking to see how well we can work together to really address these gaps moving forward. And finally, we'll close the session with a review of the session and sort of see if we can path a way forward. So what would be the next steps in this area? Overall, our aim is that this session is to provide a forum for knowledge transfer. So for you to share with us and for us to share with you, we really want this session to be as interactive as possible. So do engage as best as you can, give your experiences, even if you have no particular experience in gender and health economics, your perspectives are still really important. Why not? You know, what has been preventing this? You know, is it research funding? Is it others? So all of your perspectives are really important to be sharing. Peer-to-peer learning, and we really hope to really help use this session to set the agenda for this going forward, both within the WHO, who's hosting this session today, but also in the research community largely. Next slide. So just a little bit about who we are. So I'm Michelle McIsaac. I'm an economist who works in the health workforce department at the WHO. I oversee the program of work on gender equality, human rights, and equity within my department. Then we have Helen Barroy, who's sitting here in the front row, who's a health financing expert, quite well known in the field, and who sits in the health systems governance and financing department at the WHO. She's working starting to look into this area of why there's less research in the area of health financing and gender. And then we have Vlashnik Govender, who sits in the sexual and reproductive health and research team. She was also an economist, so all three of us are economists, which was what brings us here, and our particular interest in gender as well. Next slide. And we, for this session, have brought together a set of experts in the field. We had Felicia Nall from the University of Miami, who was to join, but was held back and unable to be here. So we have four speakers with you today. We have Beverly Asu, who's from the University of Toronto. We have Asha George, who's from Cape Town, from the University of Western Cape. We have Raji Parakash, the independent research consultant from India, who has a long history working both in and outside of the government in economics and in health. And we have Sophie Witter. And so these speakers are the ones who will be really doing lots of the sharing and interaction with you. And us as WHO, we're here in listening mode, and we're here to help facilitate. Next slide. So just quickly an overview of how we're running the day. I will do the best to keep time and keep everyone rolling, and that's my capacity really for today. Volashni will start with a who's in the room. So as we said, we want this to be an interactive session. We want to be responsive to where you are. So Volashni will open up with getting a sense of who is here. We have virtual participants as well that we'll try and bring into the session as best that we can. And so we'll be doing some things interactively with Slidos and others to ensure that everybody is able to engage. Then we're moving into a learning session, which will be facilitated by Asha George. And this is really to look into gender and health systems or health economics. So what are some of the approaches we've seen in this area? How is this being integrated? How could this be integrated better? What is gender? Why are we here? And then we have the sharing session for which Beverly Sue from the University of Toronto will present some of the work that she's been doing in the area of health workforce and integrating gender and health workforce. We have the session on health financing, which Sophie Witter and Helen Boyer will see, and the sexual and reproductive health, which Raji and Vilashni will do. Then we'll break out into the discussion session. The idea here is we'll do 3 breakout groups under these 3 themes of workforce, financing, and SRH. In the room. And then we'll come back and talk about what we've learned. The idea for these sessions is really for you to engage with us, to tell us what you think a research agenda in this area would need to look like, what the gaps you see, how you see these being filled moving forward. And we'll report back to plenary to see if we can get a little bit of an agenda moving forward. And then we'll conclude and evaluate the session at the very end. The session is meant to run from 1 until 4:30. Our break is around 2:30. Next slide. So I'll pass it over to Volashni, who will start us off.
Okay. Hi, everyone. Hope you're all feeling a bit energetic today. It's just the pre-Congress. It's a Sunday, but hopefully not anyone's too sleepy in the room. So we have a Slido now just to get a feel for who's in the room in terms of your experience working in gender and health economics, maybe none at all, but just help us as we move along. So if you can see the code. There's a Slido code. Does everyone have access? Okay, good. So can you give me a show of hands if you're not able to open it? If you, okay. Is anybody still trying to open the Slido page? Okay, we'll wait until we get to the first question then. Everybody good? Yeah, okay. Fabian, will you take us to the first question? Thanks. Okay. So if you open the first one, which country are you joining us from? Go to Slido. Okay. So it'd be great if the online participants can join us as well. You're welcome to share.
While we're fixing it, I see that we have some Francophone colleagues in the room, so feel free to speak in French. I'm happy to translate your insight, inputs, questions. It's absolutely fine.
Thanks. Just 1 minute. Let's see if we can have it open. Yeah. No, that's it. No, it's the back one. That one. Is this one here? So open. The first question here. Which one here? Where's the other one? Backgrounds here. That one. Yep. Yeah. No, go back here. Yeah. And then you open this one and you present this question. Okay. Yeah. Sorry, we're just trying to find our feet. Ah, okay, good. Okay, so we have a lot of people from Germany in the room. Great. And India, Burkina Faso. Excellent. So if there's any French speaking speakers. Great. I think we've got all the continents covered, maybe not the Americas. Well, North. Fabulous. Okay. And Canada, yes. Okay. Shall we go to the next question? Fabian, thank you. So the next question, just to get a bit of idea of your background and your experience working in gender health economics and health systems. Ah, okay. So everybody's worked on. Oh, no, I think it's still relevant. So great. Isn't. Maybe just refresh yours. Yes. Okay. So good. We have a lot of people, at least half or less than half. Sorry, I'm speaking to economists, so let me get the numbers right. Less than half with experience in gender and health systems, a quarter with gender, and of course, you probably would have some that are overlapping, and about 20% gender and health economics. Super. That's helpful for us. And then the last question, Fabian. And lastly, so the last question is just an open text. What are your expectations from this session? Okay, this is super helpful. I think we are kind of aligned with your expectations. Hopefully, you'll let us know by the end of the session. But I think one is around the learnings around the issues, the topics, the research gaps will come to, which will be a consistent theme throughout today. And then we will have a much larger set discussion on what potentially the gaps are, research issues and topics, and also about some of the frameworks as well. So, and Asha will speak more to that. And on that note, I'll hand over to Asha. Thank you.
So thank you. It's really great to be here with you. My name is Asha George. I'm a professor at the University of the Western Cape, and welcome to Cape Town, where we are. So I'm going to take you through a little bit. So my background is I actually have a PhD in development studies, but really, I started working in health systems. I was working at a district level in India, and we started following up on women who had had obstetric emergencies and were either had near misses or had died. It was a district where they said there weren't any, that, you know, the numbers were so low, it wasn't worth following up. And then once we were based there and living there, we found out actually most of these deaths weren't being reported. And that's why the maternal mortality, that's why it was so, it wasn't perceived as a problem. And it began to really change my whole view and understanding of the health system and all the gender biases involved. So that's a little bit of my background. And what I wanted to take you through, I had a slide that shows you, so there's a mix. There are people in the room who know about gender and health economics, gender and health systems, and some who don't at all. So I wanted to show you first with a grounding on what are health systems, and then bring in the aspects of how do we look at it from a gender lens. So I had a slide, all of you will be familiar. If we can go to the next slide. Many of you will be familiar of the health systems building blocks. And I think that's what comes up next. Can you press next? Yes. There's I think here. Yeah. Are we in presentation mode? So how many have you seen this framework? Many of you will have seen this framework. And there are, it's an enduring framework. There are many critiques of it. There are limitations around it. But I work in maternal and child health quite a bit. And the building blocks are things that people remember, at least. So I wanted to just put that out there as a starting point. It's a very dynamic session, as you can already tell. So what I wanted to show you is a little bit, one of the critiques is that it gets, while it's enduring and people are able, it's very tangible. You have, like our session today, the health workforce, financing, you know, supply chain, it's very tangible. But what is missing a little bit from this is where the people and the relationships, and there are many other things missing from it as well. So what I wanted to show you is I went to another WHO page. So where I went to another WHO page, and it was the photo gallery on COVID-19. And because I'm, you know, my PhD was in ethnography, I really look at visual things, and they tell you a lot about what is important or what people perceive around things. So what I wanted to show you, and it's going to come up, and I was going to lead you through what you saw in those photos and what do they tell us about gender and health systems. So there's a photo of, there's a room. Here we are. Okay, so the idea was to go from the building blocks to a very recent experience. And this is a little bit, so I want to go around the room and see, just talk to people. What do you see in these photos? And what do they tell you about health systems? Any observations? And I have the mic so that those can follow in the room. Or not.
So I see men in business clothing, like probably making decisions, and women carrying children and cleaning up.
Very apt. So there was a commentary, and I think UNDP tracked all the COVID-19 task forces around the world. And I think it was something like, I don't have the exact, do you have the exact statistic? Something like 24% had women in those task forces, and women in leadership position was even less. So that was a dimension that really was called out from the COVID-19 experience. And then a lot of people think of health workers, but people who clean hospitals, who keep hospitals clean, are also part of the health workforce, and they're often not thought about. Any other observations? Let me come.
What's going on with the guy with the pineapple?
So that was a photo on, I think it was meant to look at the food chain, which was also part of the COVID-19 story, but I'm not sure why they put someone, but I think the idea was nutrition is important, and that's also part of our health system. There is a whole line of research on gender and climate change and how women are involved in agricultural systems, agricultural labor in ways that are not recognized. Let me stay in the back of the room just one last minute. Anything you'd like to pride? Anything else you see in the photos?
Yeah, pretty much women in the front line, and the common men in suits, mostly.
Yeah, there's going to be a session on the health workforce, and certainly women were at the front lines. And one of the commentaries, there was a really good article from Brazil that looked at perceptions of health workers, from community health workers to nurses to doctors, their perceptions of safety and their concerns during COVID-19. And there was a real issue of who had access to PPE. And who was prioritized in the health workforce in having access to PPE. The other issue is how PPE is made. And usually PPE is made to a standard male body that doesn't fit a lot of women's bodies in that sense, or the range of even not all men fit that standard either. So there's some issues there. Let me come around to this side of the room and see who.
Yes, I see a tramway with people inside, everybody looking at his smartphone.
Yes. And so how do you relate it to health systems?
I see transport, that may be important, but for each people looking at his phone, maybe lack of discussion or interaction. Don't know.
Thank you, Joel. So transport was a major issue in terms of whether health workers could get to work, whether patients could get to facilities, many different aspects of that, who was allowed to travel or not. There is the issue of information, and everyone was on a phone. What were the implications of that in COVID-19? Anyone else hovering around here? No? Any brave, Philip?
So I see the guy in shorts, and it could be something about the environment, or and so many trees, and
So what Philip is pointing to is this man here in the bottom corner. That's actually a different issue. That's a traditional leader. And but in a lot of communities, traditional leaders are usually men. So that's another way in which power dynamics are need to be negotiated when you work at community level. I think in terms of digital and COVID-19, the term infodemic, people had access to information. And that's that poster there, 500 millones contagiados. Like, there was a lot of ways in which health information traveled, some in good ways, some in less positive ways, and a lot of fear and distrust of public health messages, particularly amongst marginalized communities. And I think there's a gender analysis to be made in terms of who was more distrustful of public health messages, who put on the masks and who had trouble putting on masks. There's a gender analysis there. So that gives you a sense of there are different ways of looking at health systems, and there are, at our school, when we teach, we start with, while the building blocks are there, we start with people drawing pictures of what they think a health system should look like. I think there are at least, someone did a review, there's something like 36 frameworks in health systems. So it depends what your focus is and what the health condition you work on. It really can be very, while we have some universal principles, it is important. There are very context specific details. And there are so many interlinkages, from health services to supply chain, to health information, to intersectoral coordination, to political leadership. There are many different dimensions in health systems, and they all have a gender dimension. So let's go to the next slide. Oh, yeah.
oxygen and vaccines as an issue that they thought. And PPE was another response. Precautions taken at workplace and how did the workplace respond during COVID-19? So gender dynamics there too. Just wanted to make sure they're not left out.
And I'll look to you maybe to bring those voices in. So let me keep going. I had this, there is the Alliance for Health Policy and Systems, and you see here, there's several parts of WHO that are with health economists there who are leading health systems work. But I thought this was an interesting definition and work from the report, Everybody's Business, back dating in 2007, defining health systems, not in terms of the building blocks, but all the organizations and people whose actions are to promote, restore and maintain health. What I thought was interesting, just like in those pictures, it's about actions that directly improve health, but also the determinants of health. And I thought it was really, if we look at here, who does a public health system involved? In their second line, they include a mother caring for a sick child at home. There are elements of gender, even, you know, if we look for them, even in WHO documents from the 2000s. So we're here 15, 20 years later trying to raise interest in this issue, but there is understanding there. Similarly, the last point on intersectoral education, a key action in terms of women in the health workforce, being able to recruit women into the health workforce, has to deal with the Ministry of Education and getting women's literacy up, particularly in rural areas. So this was a landmark report. I just thought I'd bring it back to show that elements of gender are there if we look for them. And my main point, I don't know if it'll work, next click, is that gender is also everybody's business. It's not just health systems. Are there any comments online? No. Okay. So let's keep moving. So I had a session on, we already started talking about this. Who are the people in health systems? If you can press click. And I put some of the things that we've seen already. If we're multi-sectoral action, there are collaborators, but there are also sectors that are harmful to health in terms of pollution, the way roads are built don't always align with health. Co-production is a big theme in health promotion, patients requiring care, and already someone mentioned who provides that care is gendered, consumers, citizens, providers. I put in artists because I think our health world would be a lot better if we had more artists involved, but everybody, it is everybody's business. But is there an observation about the words that are up here? Any reflections from someone who hasn't spoken yet? I'm going to come round. No? Mary? Yeah, so if you can press click. This is our health systems world. We use terms where they could be men, women, trans populations. The health systems vocabulary is intentionally or explicitly, you have to go dig deeper to understand really who are the people involved, whether it's by gender, class, ethnicity. When you're doing work in health systems, our language itself tends to neutralize and hide the people who are actually involved. Helen?
On the other hand, I don't know if it's the same in all languages, but in French, you use some terms like sage-femme, which are very gender-oriented. A midwife can be a man, but just the way you define it already gives an orientation to the workforce, basically.
Thank you. And you're right. I think when most people think of nurses, they think of women, and there is midwifery, but they're not always synonymous. And certainly there was an analysis of nursing in the UK, and they showed that male nurses were more likely to get promoted into positions of seniority faster than female nurses. So there are gender dynamics even in a female dominated profession. But you're right. And this, my basis is in English, and it might be different in other languages. So we really want to talk about the people involved, and it's a field that you don't get a sense of gender, and it's also a very heteronormative space. We don't talk about sexuality. And yet that's also part of the dynamics of what happens in the health workforce and in other aspects. Okay, should we keep going? How is everyone in the room? Following? All good? Oh, good. So I'm glad some of the animations did come through. All right, so let's have a few slides on what is gender. I have this cartoon here. So I wonder if I get some reactions. What do you see in this cartoon? What do you think it means? Annie?
Great to see you. Good to see you. I mean, it's just typical stereotypes of men and women being depicted. Yeah.
Anything else? Do you want to add anything?
I think gender is pretty much you're told what you need to like or dislike, and then it's made that way, whereas sex is very clear and it depends on how you're born.
Great. Anything from this side of the room? So gender, these are norms that are widespread, that are defining.
I also see action man and passive girl speak to me as like gender role and given role from society.
Yeah, so they're not just, there's certain kinds of norms. It's not like I like blue and, you know, and that's already gendered, blue and pink, but that these norms have implications for enabling certain types of agency among some people and not against others. Do you want to press click, please? So my sense, I just wanted to give a definition, and I use this cartoon, is to really look at these are social expectations. They're set by societies. You might be born, they're populate, you know, we're born as girls, boys, or intersex, but really from the time from even when you're born, people ask, are you a boy or a girl? Like it's one of the defining elements of how we're organized as societies. And it changes over time. It can be slightly different. And it definitely, if I think of my generation, my grandmother's life, my mother's life, and my life are so vastly different. So it is something that's changing all the time, but not always in one direction. And we need to be mindful of that. Should we go to the next slide? This is one other cartoon. Who wants to look at what do you see there? Any thoughts? Who's brave enough?
No.
No, you're good? Someone from the back?
Well, I think this is what you just said about generational changes as well, that and I'll add things change at different rates in different social strata, like expectations of girls are different in different social stratas as well. So this is, yeah, here's a young female engineer and her old stereotyped parents or grandparents that she has to deal with.
Thank you very much. That's a very good synopsis. Did you want to add?
Yes, thank you. Well, for me, it's also about the language that is being used here. So cute is generally what the word is being used for girls, whereas boys are usually described with other terms.
Thank you. Thank you very much. Anyone else in the room? So if you press click, those are the points. So one is generational change, expectations that carries through from the first slide. And what I wanted to say is that just because it's the social norm doesn't mean that people agree with that social norm. And that's how change happens, is that there's always dissent. That's how power works, is that it's not a static given. And so there's always the possibility of resistance. And we see now in many of our societies, there's a conservative backlash. So that's why I said it's not always in one direction. People can change their mind. So, and that's how change happens. I put this in here because a lot of our work is about gender ends up talking about men and women. But I wanted to ask, is gender the same for everyone? Does anyone recognize who this is? This is a very US example, but I want to just see, is there any recognition? Almost? No? You know, press next. It is, can you press next? Sojourner Truth. So almost, but this is a very unique part of American history, but I wanted to talk about it because we talk about intersectionality a lot. And Crenshaw brought the term intersectionality to really speak about how Black women's lives weren't being represented by either the women's movement or by people working for civil rights, that it was at the intersection. But actually, some of these issues that women are not all, don't all have the same interests or are not treated the same, date back to much earlier, to, in this case, way before in terms of the time of slavery. We have activists, people pushing for change, thinking about these issues over centuries of time. And it's important we recognize the history of these movements as well. And that's why I put that in there. She really reminds people that not all women are treated the same. And in a very explicitly sort of, ain't I a woman as well? Like, whose rights are you talking about and how do we get included? And I think in today's world, the application is just to not assume that there's a commonality of interest, that we should always ask who's not in the room. And I think particularly because a lot of policy recommendations are sort of, okay, is there one woman in the room? But who is that woman and who does she represent? What kind of background does she have? And who else should be in the room? Or who are our decisions for? We need to go beyond, as Mary said, the binary. Usually the binary is used to talk about sexuality, but there are many other dimensions as well that we need to keep in mind. All right, next slide. And I have to speed up. So my main point here is there are ways of thinking about gender that that go beyond disaggregating by sex, that it's important to disaggregate by sex. That's your first point of analysis, to just see what are there differences, to get a basic descriptive feel. But then we need to go further than that. And this is drawing from different elements of gender theory. And I think my main point is really a lot of our work is sometimes at the level of individuals, you know, disaggregating by sex. We understand gender is interpersonal, so there's a lot of work on social norms. But really, if you're interested in shifting gender, a lot of our work looks at structures. How are laws made? How are resources allocated? How do we develop those norms? And we need to work at that level as well. So if you keep clicking, it's negotiated. That's what we talked about. It changes over generations. It's contested, but it's also linked to other forms of social inequality. And that's why I wanted to bring in, some of you will have be familiar with this intersectionality wheel, which really looks at just how, at a macro level, how these different things shape each individual. So let me go into how do we bring this together now? Gender, we looked at what were health systems, we looked at gender, how do we bring them together? Can you press click? Keep going. So I wanted to, part of my, you know, it's one of my, I think we should, there are always new people in the room. And I just like to introduce like the history of ideas. I stand on the shoulders of many women before me, many men who have had amazing ideas. So really some of the initial thoughts of articulating gender and health systems, this was a seminal article in 1997. Hilary Standing began to pull these things together and has a review article that looks at different components. There's more recent work, if you press click, and I was really pleased that Sophie is going to pick up on this. We were part of a network that looked at gender in health systems. The website is still active, and there's a lot of resources there if you're interested. And we looked systematically at how gender was involved, affected all the different elements of the health workforce. And we'll be talking more about that, but I wanted to put that there as a resource. Can you press next? So I'm going to talk about two ways of looking at gender in policies and programs. And we talked about gender, how it's part of social inequality, how it structures the society. Two analytical frameworks that help us understand how does it affect programs and policies when you implement things. And this comes to who, before we go to the next slide, who is familiar with the gender responsive assessment scale? Anyone in the room? Would be good to know. Has anyone heard the terms gender specific or gender transformative? Does it ring a bell? Someone, I see someone tentatively putting her hand up in the back. No, it's okay. And let me, while I pass is there anyone online who knows what gender transformative or gender specific?
Carol, I raise my hand because I've heard of it, and I know I'm supposed to consider it in new projects and in grant proposals.
So you're in the right place. Well done for being brave, for admitting what you do or don't know. So this, Joël?
I heard that it's about budgeting. Yes, budgétisation sensible au genre.
So maybe in French it has a different connotation, and certainly budgeting is where power is. So you're on the money on that. So this is a scale. It comes from development studies. There's a whole history behind it, but WHO has been using it to try and categorize programs and policies. So if we go to the next slide, it's giving you a sense that we can look at policies and programs and classify what are the implications for gender relations. So there are some programs, they have a continuum. There are some programs that are profoundly unequal, that distribute power or acknowledge people in different ways and perpetuate inequality. Those are gender unequal. There are some that are gender blind, and I'm going to give you, in the next slide, we'll look at examples, but we're not moving yet. They look at, they're not intentionally trying to be discriminatory. Just like the language I showed on health systems, where all the terms are essentially gender blind. You don't know if it applies to women, boys, girls. It ignores gender norms. They really don't look at gender. There are others that recognize there's a problem, but feel it's someone else's problem. So if a woman is, coming to a health facility late and the community didn't support her coming to the community, it's sort of, well, a health worker could say, what am I supposed to do? That's not my, yes, it's a reality, but it's outside my remit. That would be a response that's, you're acknowledging there are problems, but you're assigning responsibility elsewhere. Then there's gender specific. There's programs that look at and see there are specific needs. There are different needs. Women and men have different needs, and we need to respond to those needs. But fundamentally, it's not changing the power relations underneath. And that's why we have gender transformative. That's when you might be addressing needs, but you're also trying to change the nature of those needs or the power, the fundamental basis of the social norms underpinning them. So that's the theory behind a lot of this. Let me give you a few examples. How does this apply to health systems? So can we go to the next slide? So this is, as I said, while WHO has this scale, it borrows from a lot of work from public policy and development studies. So how do you think, let me go around the room, how do you think health committees or CHW programs could be seen as exploitative? Is there someone here who hasn't spoken? Sorby, any ideas? No? Anyone else? Community health.
So one thing that I've heard is community health workers are mostly women, and therefore they're either considered as volunteers, so you don't really pay money to compensate for their work. And if they were men, maybe policymakers or program designers would have considered some salary.
Thank you. So it's a given that, and it's a contested issue, whether you should pay community health workers. There's a whole range of community health workers, but I'm just pushing the label to think we don't think of them as exploitative, but expecting women to do things for free, and the number of things that community health workers are meant to do just increases and increases, and there's no recognition that that is valuable time. And that time needs to be compensated. It takes away from other responsibilities. And that understanding, Beverly's going to touch about this in a different way, is how do we think of women's time is very gendered. And we've sort of normalized that community health workers are volunteers and they don't have to be paid, and not looked at that more. And then what are the implications of that? Health committees. Who gets selected to be on a health committee? You saw the men in suits in COVID-19. Who were the people in the room? You know, there are ways, I mean, this is using very blunt language, but calling things as they are. Why do you think health insurance schemes could be gender blind? Anyone in the room? Any thoughts? Keep thinking.
It's a tentative because, for example, the contribution don't take into account many aspects. So everybody is supposed to contribute the same, but we know that in many societies, women are in less social economic advantage compared to women, but we apply the same criteria for everybody.
That's very valuable. Did you want to add to that, Heather?
Maybe also based on risk profiles, which looks at smoking, drinking, other underlying health conditions that don't differentiate between male and female.
Thank you. So those are two different points. Yeah. Okay, good. Everyone's jumping in now.
No, I just wondering, like, they do differentiate between men and women, right? Because I'm from Mexico. I live in the UK, but we're still paying our insurance in Mexico, and they charge very differently, like mine, than my husband. So they charge us more to me.
So sometimes that risk may be charged unfairly. But just like in a very different world, men's haircuts are very different from women's haircuts. I'm just taking a very different example, but how is that risk determined, and who makes those decisions, and whether they're based on ability to pay? The issue, what Joelle brought up, was we assume some health insurance mechanisms are employment based, but we know that a lot of women are in the informal sector. They're not going to access that. So there are ways, that's what I'm taking what you said, Joelle, is we are blind to the way in which the workforce is placed differently by men and women, but our health insurance schemes might not take that into consideration. It's blind to that. It might be blind to whether some women's health issues are actually covered. So I think there was an old analysis that looked at Viagra was covered, but certain basic maternal health or safe abortion is not covered. So do others want to jump in?
Just to complement what Joel said, in settings where enrollment to insurance is voluntary, sometimes and contributory, it depends on the ability to pay. So it means that in settings where, like in Africa, we know that men have more capacity to contribute more than women. So in that, it's a different story when like enrollment is compulsory, where everyone has to enroll. So this can be also a case. Thank you.
Thank you. So ability to pay and who holds the purse strings in a family. Jessica, did you want to add something?
No, I was just noting about the selective, the covering certain health presentations depending on, gender. I was thinking about menopause in your example, that sometimes in some health insurance is not covered, but like, sexual kind of health, like Viagra is. So it's interesting. Yeah, I just wanted to add that.
So my presenters will provide much more specifics on this, but I wanted to take that theory and apply it to these different ways we can look at how gender power relations, how do they interact with programs. Looking at voucher schemes. So I worked with Makerere in assessing a voucher scheme in Uganda. And it's an accommodative approach because it looks at specific needs. But I don't know, actually Philip wasn't part of that team, so I'll keep him safe. He's looking down at his phone. But why would that was a voucher scheme to give women a voucher so that they go to antenatal care that paid for their transport so that they would increase. So it's recognizing a need. Women were not in rural areas able to get to health facilities easily. They gave vouchers so they could pay bodo drivers to take them to the antenatal care. So it's a good thing. What could go wrong?
So in such voucher schemes, usually what happens, a woman is expected to have some credentials or maybe some, identification. But this happens in India also. So women from rural part, they do not have a basic, account in bank accounts or maybe the identification card. So they are left out of these voucher schemes. So even if the scheme is applicable to them, they are not able to access it. So that should be taken into consideration as well, or maybe some form so that she is able to access such schemes. Thanks.
Thank you. So that's speaking to whether people have a lot of even digital programs. Do women have phones? And then digital banking, do they have the follow-up when you set up a scheme? Philip?
So something that's a bit, it does not solve the ultimate problem of why they need this voucher,
That's right. It didn't look at saving patterns in the home. And one striking thing is these are dynamic relationships. So one thing that started to happen is women showed up with these bodo drivers who were men. And because men are going to lose income if the woman, usually what happens in a maternal child center, when do women go, what time do people go to a government health facility? And how long do they spend there? All day. Women go for an antenatal clinic and they spend all day. Suddenly they showed up with a bodo driver. He has other rides to give. They jump the queue. So it's like these unintended ways in which gender power relations operate. And you can't keep a man waiting. You can definitely keep a woman waiting, but you can't keep a man waiting. And so these were the unintended ways in which you implement a program, but it fits into different valuations of people's time, authority, and it begins to change dynamics of who gets attention. But are they getting attention for the right reasons? That's what we have to also assess. And so we get to things that we really want to change gender norms. We have to look at social norms, who has access to resources, decision-making, all these other things, and it has to do with changing everybody in the room. So I'm going over it very superficially because we have presenters who are going to get into this in more detail. So I have one last slide and then we'll come to 2 o'clock. So that gives you a sense of how that gender theory is applied to assessing how programs function and what do we have to watch out for. I'm going to present one last framework, and this is some work I did with Michelle and others in highlighting one issue that I think is underrepresented in the health workforce, and that is violence that happens against health workers. There's emerging work on how over time we've recognized that women who seek obstetric services face abuse, and that whole arena of disrespect and abuse has finally become acknowledged, and there's work on that. There's a lot less recognition of even measuring what happens in the health sector for the health workforce in terms of basic working conditions, and as part of that, their exposure to violence for different reasons. And there was an editorial that's come out recently in the BMJ looking at violence against community health workers specifically. But the reason why I put this out there is it's a framework for thinking about power, because gender, as I said earlier, is about thinking about power relations. So how do we apply that? And we came up with this figure that the violence that you see is the tip of the iceberg. It's what you see. But what makes women health workers particularly vulnerable is a whole array of things. But those gender inequalities are linked to gender biases that are founded in fundamental ways in which power operates. Okay? So I just wanted to put this out there as a framework to begin to come back to what are power relations. Key things about what is known about a topic. Persistently in health systems, there are some topics that are just not acknowledged. So it's a shame Felicia isn't here because she's a champion for many things. One of the things is she put palliative care on the map, you know, and that was an area that wasn't, there are a whole number of issues that stay in the realm of the unknown, in the realm of the unmeasurable. And that's a key way of hiding a topic and making sure that it doesn't get addressed. So really looking at what are the data gaps. There's a lot we don't know of. We're not actually measuring the extent of this problem. Just like there's a research agenda on measuring women's time effectively. Who has what? That's another key question in terms of power. And that links to what kind of resources are allocated for men and women. And this issue in COVID-19 came about in terms of who has access to PPE. But it also could be access to training, who has access to training, who is considered for promotion. These are all different ways in which resources are allocated that puts some people in a lesser position than others. Who does what? That's a basic question, is the division of labor. And in the health workforce, that is ingrained in our hierarchy of professions. So it's almost, it's embedded in how we think of the health workforce itself. But we need to be mindful of that and think of what are the implications. What is valued? So I put that there because a key question is, how are norms shaped? When we see a woman in a decision-making position, we look at her differently from a man in a decision-making position? How is authority viewed? And all of that has implications in terms of women actually being in positions of leadership to change policies. And that comes to who decides. So I'm just hoping this visual is one way to remember that when we look at gender inequalities, it's key. You can look and measure these things, but we need to look deeper at trying to understand what are the things that drive these inequalities to be able to better understand how we change them. I'm assuming there are no online questions. There are? Someone else? Any thoughts and reflections from the room? I've been talking a lot, so anyone who hasn't spoken, let me go around. Does this resonate with anything you're doing? Let me come here. Julia? Any thoughts? No? Your brain is frozen?
No, it's not frozen. It's active. No, I think it is lots to digest, lots to definitely to think about. Yeah, no, I do. The majority of my work is with adolescent girls and women. So somehow I'm missing out a lot on the other parts. So for me, gender is very much embedded in all the work that I do. And somehow my issues is not men versus female, is how to include non-binary into the female. For example, I work a lot on menstrual health, and in countries which is quite sensitive, and menstrual health is for women and girls. But we are encouraged to call our participants menstruators rather than women and girls, so that it's inclusive. And sometimes one of my challenges been how to then be sensitive to the local contexts where menstruators is not a word, and it has to be women and girls. So I'm facing different type of challenges because I've always been working on what I would say women's health. But then again, is it women's, or who is a woman? Then there was this very provocative front page in the Lancet a couple of years ago. Bodies with vaginas have been neglected, and I found that extremely offensive because they're not just bodies, right? They're people with vaginas. Are they women? Who are they? So I think that this is one aspect, is the gender inequality, but yeah, who is a woman?
Thank you very much for sharing and bringing the different ways in which this is an evolving field that is full of contestation. I want to check if there's anyone wanted to add to what you raised. I think it's a real issue in terms of both recognizing discrimination and the needs of marginalized populations, but also recognizing not erasing other people's histories, other women's and girls' histories. I'm just going to go through the room as we close. Anyone else? Sir, any thoughts?
Yeah, thank you. So something that occurred to me is when I hear gender, I think it is not only exclusive to women and girls. And one example that came to mind as you were speaking is I recently learned about this phenomenon in certain ethnic groups in Niger. I recently learned about this phenomenon with certain ethnic groups in Niger, whereas the men will not go to the birth of their children. And at first, from a Western, I guess, vantage point, that seems kind of highly questionable. And but once you start digging down deeper, the reason is because if they appear at the facility during childbirth, they will be asked for large sums of money, and their partners will be basically held captive until they pay. And so I think that could be an example of a couple of things. One is the interactive effects of gender within the area of health financing in particular, and access to care, and also how some of these social norms and what have you can have negative impacts on women and girls in particular, but also their partners and families. And I think that's an important aspect of the discussion as well. Thank you.
Thank you for sharing. So that's both about social norms, but also how policies around who pays for healthcare and how we finance the health system has implications for who ends up going to the health system when a woman delivers. So it's both cultural norms, but also looking at how are health facilities coping and how do they interface with families seeking care. Very powerful. Just any last comments from this side of the room? I'm very mindful we've been talking for quite a while. I think this sets us up for the rest of the afternoon. I really want to thank everyone in the room and those who stayed online. Thank you for joining us in this conversation. We have a lineup of fabulous people who are going to present and do a more deeper analysis of each of these segments. I don't know if you want to break or do you want to stay in the room?
Yeah. So we'll do one of the sharing sessions first. And thank you, Asha. That was a really wonderful overview. I mean, I think one of the really interesting things is we could do an overview for a full day because this is such a deep and broad issue. And I think even if you just look at the health systems building blocks, you could do a full day or a full year, I mean, on any of those building blocks and the intersections of gender and other social stratifiers in those elements. And I think we're going to do 3 kind of deep dives or look into 3 of these issues. But I think the main thing is to think of how broad this issue is and what is getting play essentially at the political level or other. And I think it's really interesting for Bev to present this on health workforce, because I think from the health systems perspective and as an economist in the health systems, one of the things we really noticed is that there was a lot on women's health as sort of being the gender everything, right? And we know that there's gender outside of women. We know that there's, men's health, or we know that there's a gamut of things here that aren't being looked at. And we saw a Lancet Commission in 2016, which Bev is going to talk about, that really tried to say women and health. So which are the ways that that gender and women interface with health and health systems that isn't just the outcome of sort of their bodies and others. So with that, happy to pass it over to Bev. We'll break probably 10 minutes later than we were anticipating, but we'll still make sure that we have our coffee and our break to discuss after this.
Hi, everyone. So my name is Beverly Esue. I'm an associate professor of global health at the Institute of Health Policy Management and Evaluation at the University of Toronto. And it's a real pleasure to have an opportunity to join you as part of this session. And so I'm quite grateful for the invitation to contribute. I also want to acknowledge up front the privilege, I suppose, that I feel I have to be able to be here in person. I experienced some travel delays in terms of getting here, travel complications, and was able to kind of quickly pivot and reroute, et cetera, and still be able to attend here. And I know that privilege that my passport affords me is not open to everyone. And so I just want to acknowledge that up front. Okay, so I'm going to speak about 2 areas of work that we've been developing over the last number of years that are focused on measuring and valuing health work. Michelle is correct in that this work builds from a Lancet Commission on Women in Health that was led by Anna Longer and several others. 2015, 2016 is when it came out. What we have been developing in this work is seeing sort of a convergence of thinking that predated this work from the feminist economics literature with labor economics and health economics in really interesting ways. And what I want to try to pull together are the opportunities, I think, for those of us who wear the health economist hat to sort of take this work forward in terms of development of methods and in terms of the application and integration of some of these methods into some of our more routine models and frameworks. And I apologize because I do have some animation, so I'm gonna navigate you through it. Okay, next slide, please. So some of the work that I'll speak to is being developed in the context of quite a large global collaborative. We call ourselves the Gender Equity in Health Systems and Caring Economies. There are a number of folks who are based all around the place, and I want to acknowledge up front that I'm presenting some of this work on their behalf, and also want to acknowledge Hoden and Isabel who contributed in part to some of the slides. Next slide, please. Okay, so I think for many in this room, these reports will not be new, but I thought it was important as a starting place to point to the fact that the idea of thinking about gender and health systems and gender inequalities in health systems and health work in particular is not a new concept. There have been major reports by major institutions and organizations over the last decade that has really raised the profile of this issue and highlighted the gender inequalities that exist within the health workforce. this is not at all intended to be an exhaustive list. It's certainly just a subset of reports that have come forward. But I think across the collection of reports, they've really served to highlight the gendered nature of health work, the disproportionate share of unpaid health work that's borne by women. Quite importantly, the issue of occupational segregation that exists within health systems, such that women tend to occupy lower tiered positions, and even within occupations, there are inequalities in terms of the route to leadership, which Asha laid out quite importantly, such that, you know, even with efforts to bring additional individuals into the pipeline, if you will, there are issues with the pipeline that allow careers to sort of stagnate and not necessarily progress at the same rate. And then importantly, when assessed through an intersectional lens, which has been applied much more recently, we see that the opportunities and efforts to address gender inequalities in the health workforce have not been enjoyed by all women, with racialized women and gender diverse individuals sort of overrepresented, and it's a persistent overrepresentation in lowest paying and least secure positions. And in underrepresented in leadership roles. So much of this work has grounded some effective advocacy to really raise the profile of the issue, but has remained in large part somewhat siloed in an advocacy space. If you can click to the next slide, please. And then I think you have to click one more time, right? So when we look, you know, we haven't yet seen this thinking sort of mainstreamed within health workforce planning, and indeed not within work that is going into sort of developing universal health coverage, priority setting, and resource investment decision making. And so this was a very quick and dirty attempt to look at what's happening in the literature when we look at gender inequality in health workforce planning. We certainly see in, you know, in PubMed, which reflects, you know, it's not discipline specific, certainly in the last 10 years, there's representation of papers on this topic within PubMed. When we look to the discipline-specific databases and Health Economics Journal, the Health Economics Journal, which is but one, much lower representation of articles that are sort of taking on this issue in title and abstract, so real focused on the topic. And so the purpose of putting this up is to show that while there has been attention to the issue and to raising the issue as an important factor, it has sat somewhat outside of the dominant health system development discourse. And so there's an opportunity, I think, for us to be thinking about this and really sort of reinforces the importance of bringing this attention, some focused attention to it within the context of this pre-Congress session. So I'm going to speak to some of the work that we've been leading on valuing health work as sort of one particular area in which I think health economists have a role to play. Next slide, please. So this work builds from the 2015 Lancet Commission on Women in Health, which established a framework for really describing the myriad and often intersecting ways in which women and their health contribute to and are impacted by health system factors. So I'm not going to go through these cycles in detail. I put them up, they're mentioned within the context of the commission, but I put them up to highlight that on the left, you know, we are sort of caught in this vicious cycle where attention to inequalities manifests in ways that impact the ways in which women and girls' health are prioritized, the ways in which they're able to enjoy equal benefits in terms of health outcomes, the ways in which they then interact within roles that are expected of them in society, as well as within health systems, the extent to which they develop fullest capabilities and opportunities within the roles that they play, and it spirals in this what is characterized as a vicious cycle. And that through some reframing, there are opportunities to reorient the cycle in more virtuous ways, such that attention and prioritization of women and girls' health presents opportunities for women and girls to participate more fully within their lives, to experience well-being to the fullest extent, and contribute within health work in one instance, but in all areas of work in ways that actually are enhancing and empowering as opposed to exploitative. So the Lancet Commission put forward a number of recommendations, and there are two that I'm going to speak to today that we've been developing work over the last 5 or so years to take forward. And the first is in terms of counting women and valuing their contributions to health. You know, we hear all the time, I think as researchers, that if we don't count it, it's not, you know, if it's not measured, it's not, now I'm forgetting the way the saying goes, if you don't count it, it's not visible. And so there was a real strong recommendation put forward that we need to count the ways in which women contribute within health systems. And I wanted to say this out front, just in response to a point that I believe you had made, that much of what I'm speaking about is women and a real binary understanding of gender. And in part, and this is not a good excuse, but in part that's related to the ways in which the data are set up. And so our ability to count and value health work, which rely on data sets that really measure men and women, they're so far behind in terms of thinking about gender. And so I'm not at all discounting the important work that non-binary and individuals contribute to health systems. But in what I'll present in a couple slides, I'm speaking about women because at the very least, we're able to understand the work of women in the context of overall health work. So count women. And then the second recommendation we're doing work to take forward is this idea around being accountable to women, account for women and be accountable for them. And what that means is if we are to value the work, we can't stop there. That's sort of a problem definition, but that there are ways in which we can and should be accountable to, as an example, thinking about how do we reflect on the reliance on unpaid work within how we value interventions? Why is it that within health system development, we continue to model cost effectiveness of interventions with just this assumption that the unpaid work is going to be there as a given, and perhaps we have opportunities to be a little bit more intentional in accounting for that work. Next slide, please. Okay, so you can I think there's 4 of them. So just to this is an incredibly simplistic visual, which is really trying to highlight that there are numerous ways and health work and care work come together in various forms to make contributions within the health system. And we talk about contributions to health system in part because we want to reflect that some of those are recognized formally as work, and some of them are not recognized formally as work. And that has implications for how we identify them within data sets, how we identify them within health systems. And so I'm providing here sort of 4 characterizations that we have used within our research. The first is that there are sort of paid health workers and health professionals, sort of least contentious. You know, this is where we sort of easily identify doctors and nurses and health professionals. When we look to labor force surveys, we're also including work that is conducted within a health system. So the administrative staff that help the system to function. We also identify that there are paid health workers that may not work within the health system. So a nurse within a school is a good example, a doctor that's employed by a private company. We want to capture all of those paid roles. There are also and underpaid health workers. Asha spoke about community health workers as a sort of classic example, where their work can sit in a volunteer space. It can also sit it comes up in some labor force surveys if there are subsidies attached to the role, but it's very inconsistent in the way that it's captured across labor force surveys and in fact across time use surveys, which are the 2 main ways in which we capture this work. And then the other 2 are where we start to think about the roles within the care economy, which is language that the ILO and the WHO use to capture all of the work that is done in the context of caregiving, as well as formal care roles to support ill health within a household, within communities. So health and care work take various forms. Collectively, they filter through into a system that can be extractive, that can be exploitative, that can impact the ways in which those contributions are actually realized within health and health systems. And so while we want to capture each of those and value the health work, we also have to be mindful of the filter, if we can think of it that way, through which the health contributions come through. Next slide, please. Okay, so building from the Lancet Commission, we've been undertaking this major update to provide a gender lens. And what I mean here by a gender lens is that in the Lancet Commission, they look specifically at valuing women's health contributions. And here we're taking sort of a zoom out and measuring all health work and examining women's work in the context of all health work. We've expanded from 5 anchor countries to integrate microdata from 15 countries, as well as 49 aggregate data from 49 countries. The 2 key data sources that have been drawn upon, not just within this research, but more generally in work that is undertaken to value health work, are time use surveys and labor force surveys. Labor force surveys, because as those who are in the room who are familiar, they capture all of the work, all of the production that goes into an economy. And time use surveys, because this is the main source of capturing how people spend their time. And so we've gone through quite a detailed exercise of being able to identify health-related activities that serve the purpose of supporting an individual who has a condition, an identified illness, and there are I'm not going to go through, I don't have the time to go through the detail on that definition of work categories there, but it's intentional to focus on assisting with the purpose of assisting a person who has a need for health and healthcare rather. I say that distinction because there's a broader analysis that's been done to look at the role that women play in health promoting activities. So this is where we have sort of, cooking healthy meals and contributions to sanitation, all of these functions that are important as part of public health. Those aren't included in this analysis, but it's the focus of some additional research. And so the outcomes that we're interested here are generating country level estimates as well as global projections of the value of health work, the value of women's contributions to health work, and to account for wage discrimination, underpayment across all of these roles. I didn't say this on the previous slide, but I just wanted to come back to a point that you made about, Asha, that you made about the social norms that go into how we define those pieces. And I think it's quite relevant in particular for the care economy and the care work, because there's this idea that altruism drives individuals' interest and benefits from caregiving, such that the value that's placed on it, it doesn't necessarily get easily defined as work. And so there's some contention around what is work and what is caregiving and what is altruistic and what is not. And in taking a couple steps back, I think fundamentally we don't question the altruism behind many other roles, right? And so we don't expect other roles in the health system to work for free, but that same argument gets raised for caregiving, it gets raised for community health work. And why it's important is it impacts what then goes into this sort of valuation. So I just wanted to make that point. Next slide, please. Okay, so I'm going to give you, now these are under review, so I ask that we don't circulate this slide, but I think it's important just to give a sense as to what we're some of the estimates that we're coming up with here. So here this pie is showing the overall value of health work and how it's divided across paid and unpaid and levels of underpayment. And so what our work is reinforcing is that women are major contributors to health and to health work globally. Their work accounts for about 70% of total health contributions, which is in the order of around $7 billion in PPP. The value of women's health work is about that value, that 7.3 billion, is about 5.7% of global GDP. As you would expect, there's notable variation in this valuation between high income countries and low and middle income countries. And this is marked by differences in wages and hours across the regions. And underpayment, so, which is likely as a result of discrimination, but where we note that women are making a lower wage than men for similar work, as well as unpayment as well, no payment, accounts for about 14% of the overall value. Next slide, please. Okay. So the value of unpaid health and care work to health systems is huge. You can just click through. There's a couple animations. And so here we're capturing activities that support illness, disability, disease, disability management in the home, in the community, and volunteer unpaid health promotion work. So unpaid work makes a significant contribution. It involves substantial time costs and can have considerable negative effects on the health and well-being of caregivers. In our analysis, it accounts for about 60% of the total value, which we estimate is approximately 600 billion hours of unpaid health contributions that are provided annually, which is equivalent to about 225 million full-time equivalent positions. Globally, about 70% of all unpaid work is performed by women, who on average spend 3 times the hours provided by men in unpaid health work. And the burden of unpaid healthcare is most unequally divided in low and lower middle income countries, where women contribute approximately 80% of the unpaid work. And in part, this is related to the level of development of the health system. And so where that we see where that is the case, there is an increased reliance on individuals and women in particular to step in and take on those roles. Okay, so unpaid health and care work continues to be women's work, and that's reinforced within this analysis. Clearly, this necessitates policy responses to think about a more equitable distribution of unpaid work in particular within health systems. And I think that there's a lot of focused attention on trying to understand what that policy, those transformative policies that Asha spoke to entail. One of the pieces, and you can go to the next slide, while I think in parallel we need to be thinking about is how do we account for that unpaid work? While we recognize that it's huge and has a huge value, the extent to which we value it within our health system investment decision making is quite mixed. And so this is actually quite an older study, 2015, maybe not that old, 2015, which was looking at to the extent to which informal care and economic evaluations matters. I think we typically take a health system perspective as the payer. And in this work, which looked at a very focused set of interventions, they found that in some cases, including it did matter. In other cases, for particular interventions, it had quite a significant impact, and in fact changed the decision recommendation in one of the cases, one of 22 cases. So not huge, but the inclusion of unpaid work, the accounting for unpaid work, can potentially shift the investment decision making. So we're undertaking work to expand, to update this review, as well as to expand and look across a suite of NCD interventions as part of this healthy longevity piece of work. And so I hope to be back next year to be presenting, not next year, in 2 years, to be presenting those results. The point here is that if unpaid work it represents a value to health systems, I think we have to ask ourselves, why is it that we don't account for it more systematically and within the dominant way in which we assess value for health system interventions? Next slide, please. Okay, so in addition to assessing the value, the Lancet Commission also called for the importance of being accountable to women. And one of the ways this is being taken forward has been quite advocacy oriented. There's been quite focused efforts, and Asha spoke to some of these in her presentation, and they've certainly increased over through COVID to understand representation in leadership and women's representation in leadership. And so these are 2 graphics that are produced by Global Health 50/50 and Women in Global Health, which really make the point that by and large, across global health systems, healthcare is delivered by women, but led by men. So you can look across occupations, you can look across leadership roles. There is a persistent underrepresentation of women within leadership. Next slide, please. And so we make the case that in other work that we're doing, that we need to better understand why and how representation matters. So in part, this involves monitoring. What we have found is that the data available to actually track representation is incredibly ad hoc. It requires scraping. I came to understand this term, scraping the internet, which essentially means looking across websites to be able to pull this information on representation, because most countries do not systematically collect information on representation in leadership. And so why does that matter? Well, I mean, it means that back to the point I made, I think at the beginning, where if we don't measure it, then we don't have an ability to understand the issue or to address it. And so part of this call is to be able to understand that if we can systematically measure these pieces, perhaps it is the case that we can develop metrics to understand health system performance as, representation and leadership as a measure of health system performance. We're quite a ways away from being able to do that because we actually don't have the data systems in place. I found this paper, which I've just included a snippet of it, just came out last week, which is making the case that actually female representation in political structures is now being linked to efforts to prevent violence against women. So the idea that female representation in leadership is relevant for shifting some of those social norms that Asha spoke to is highly relevant, but the research to actually understand the ways in which that takes place is in much earlier stages of development. Next slide, please. I'll skip over this. This was just work that we did in the Afro region to look at representation across COVID-19 planning bodies, and it supports exactly what Asha mentioned. There was significant underrepresentation, which were missed opportunities to mitigate some of the gender impacts from their response. Next slide, please. Okay, so areas where a gender lens is relevant but has been given inadequate attention by the discipline. I put this up as areas that I hope that we can come back to in the breakout group that's going to focus on workforce. I think we haven't yet thought about what does it mean to apply a gender lens in workforce planning models? How do we do this in a systematic way? What are the leadership models that enhance effectiveness and resiliency in health systems, including for health emergencies? And how does a gender lens, what would a gender lens entail in terms of planning to enhance those features of the health system? UHC health benefit package development and the investment case for disease prevention are linked. We make a case in this commentary that was released about 2 years ago now that universal health coverage has to become a best buy for women. We have to plan for the we have to plan to redress the discrimination and inequalities that exist within the health force, the distribution of work within the health workforce, as well as the heavy reliance on unpaid work. And I think the next is my final slide. So as a way forward, I've identified 4 areas that we're actively working on and would encourage and would value some feedback as we go into the breakouts. We need to scale the measurement and the value of health and care work in additional countries. If we don't measure it, it's difficult to monitor, it's difficult to be accountable. So systematic measurement and mainstreaming approaches to measurement will allow for some convergence in terms of the methodologies that are used, but also the ability to add for some comparability across the different efforts. We want to distill best practices to support routine incorporation of unpaid health and care work and other gender relevant outcomes in economic evaluation as one particular way in which this work can bridge and should bridge within health economics. So approaches to measurement, relevant data, valuation of time costs, and valuation of meaningful benefits. I put up there caregiving averted, which, not all would argue because caregiving can be, for some, a positive experience. And so what are the meaningful gender relevant outcomes that could be incorporated? We're applying this as a proof of concept within a Lancet Commission on Cancer and Health Systems that I'm a commissioner on, to think through a broader, more expansive framework for assessing the value of cancer investment. And then we want to engage. We want to engage broadly with decision makers, with caregivers, with health workers, et cetera, to understand what are the meaningful outcomes that need to be incorporated. And so my final point is that, we, I think, take as a given and would agree that fair and equitable health systems are focused on ensuring equitable access, but we also need to be thinking about the environment and the context within a health system that is ripe for ensuring gender equality and promoting gender equality for the women who provide this work. Thank you.
So I think we can do 5 minutes for questions and then we'll break for coffee and we can bring our questions out. Are there any questions for Bev?
I'm not meaning to give you a hard question, Bev, but this is the professional meeting for health economists. So I think we tend to slide into what can us great health economists do for those poor programs we're evaluating. But actually where we should be distilling our best practices is what can we do to change the institutional sexism and racism in our institutions? Because every university looks like that slide for leadership. Every pharmaceutical company looks like that. Every government health funding body looks like that in high income countries. So what are we doing? What works? I mean, the Australian funding body has just brought in a policy around fellowship funding, but we don't know if it's going to work yet. It's an interesting first step. I don't think any other country's done that. Luckily, we don't have to face the legal challenges that, for example, the US does when it brings in positive discrimination. So what works? What can we do? In what universities around the world have actually made a difference? Because just sitting there and going, oh yeah, that's just a generation thing, that'll change because yes, 80% of public health students are female, but 20% of the leadership are. It will just take a generation. No, not good enough. What are we doing? What works? What works in organize? What can we do in our institutions now? That's my challenge for you.
Let's take a couple while we digest that question, which is a major one.
Hi, thank you. I'm Dylan Walters from Nutrition International. Thank you for the presentation. I have a question, Beverly, based on your experience in presenting the results of the valuation of unpaid care or if you have any experience in presenting this data, these results to national policymakers around the world, and how this type of data is received from policymakers who don't necessarily value this unpaid work, or I'm thinking in our line of work, the value of breastfeeding and milk, like Julie P. Smith's work in Australia, and how national policymakers, whether it's Ministry of Finance or Ministry of Health, view unpaid work. Do they see it as an advantage of their health system that it's unpaid, or a liability? And whether this analysis kind of changes their perspective on it or not. Just wanting to hear any feedback. Thanks.
I'll take a few more.
Hi, hello. My name is Jessica Alvarez. I work in the Department of Health in the UK. I mean, this is really interesting. One of the challenges that we have nationally is the gender aspect of caregiving, especially unpaid care. So the highest proportion of our population is older adults, and they are giving the caregiving is, highly delivered by older people that are women mostly. But the challenge is, as a policymaker, I guess, is like, how do we put that number against the value of care, so then I can make decisions to support using our own budgets. And that's really difficult internally, so that we have different viewpoints. So just thinking that the fact that we are in a health economics congress, are there any specific type of research that we need to fund to be able to use the argument on the importance of unpaid care? Thanks.
Yeah, and just to comment that the UK is actually one who's doing a very good job of integrating health and care. And I think that this is one of the things that we don't see necessarily in all countries who tend to separate these two. Did you ever hand up?
Thank you. Anna Verbeck from Germany. Hi. I have a question. Like, you were talking about the equality or equity for the workforce and for women in the workforce in the health sector. And have you also looked at the effects for the patients? So like the effect of having a female doctor, or like having females in higher positions, on how it affects like females that come in as patients, not only for female health, but in other dimensions like gender medicine in this terms. Like, that would be interesting for me as well.
like the acceptability of care.
Thank you. Thank you for your presentation. My name is Janice Barry from Fordham University in the US. One thing that I thought might be helpful in terms of looking at measurement in the 1990s in the United States, Heidi Hartman, a very famous feminist economist, as well as others, looked at comparable worth. And since unions rate the value of a job by the job characteristics, hopefully, and not by the gender, race, or some other demographic characteristic, they were able to show how certain jobs, which involved, let's say, nursing and home health aides, were able to produce a certain value and then corresponded to a similar characteristic in a job held by a man. Pardon, I'm just thinking that literature still has something to give us in 2023. Again, thank you for your presentation.
Yeah, and I think this is why when we think of the gender pay gap, we're often thinking about the occupation. So what's the gender pay gap between men and women in occupation? But it's actually across sectors that really matters as well, feminized sectors compared to non.
Hi, Heather Ingold from London School, PhD student, but also from UNITAID, HIV program manager. I wonder how I see a lot in my day job. We get cost effectiveness studies that look at, what's done in the health facility versus what's done at the community level. And I guess obviously, or not obviously, the community one is always more cost effective because it doesn't account for the unpaid costs, right? Which is super frustrating. And I'm wondering how we can maybe start to change that. Is it with the models? Is it with the data sets? Looking maybe for ideas or how we can start to do that even at a donor level. Thank you.
Is it with political commitment?
There's one more.
Okay, sorry.
Hi. Hello. Hi. Just a quick question. Hopefully it will be easy to answer, but when we talk about caregiving specifically, I was curious to know if there's an age component to that. Just because if I understand it correctly, because caregiving doesn't happen at an employment level, there's a lot of times a lot of burden given to women, quote unquote, or girls to give care to people in the family that they might be using alternatively for their studies or things like that. So when we think about the unpaid nature of that job, are we also including younger women, I guess? That's a question. Thanks.
And the simplest questions are always the hardest to answer.
Wow, 4 minutes. Okay, here goes. So I think a starting point in terms of what we can do is to even identify that this is an issue across our institutions. And so we're starting to see signals where leadership identification of the issue is setting that, like, so you mentioned NHMRC making this change. We're seeing this in part. I'm not saying it's perfect at the University of Toronto, but identifying that we need to actually monitor what the gender composition looks like among the deans, among the faculty heads, and then make concerted efforts to actually recruit in such a way that we make those changes, to think about the funding internally to create, to address inequities such that we're actually prioritizing funding for female scholars, for racialized scholars. There's huge funding that's come through, and that's we're seeing that visible in institutions across Canada. It's not perfect. It is not perfect. There's also a feeling that, well, EDI is just going to pass and it's all going to be better and we'll forget about it and move on. So it requires some dedicated effort and attention. And so, not to sound like a researcher and say we need to measure it, but we do need to measure it. And then we need to do something with it. Otherwise, people lose the will to measure. So about the question around how this has been presented to decision makers. So we've brought this research to the Women Political Leaders Reykjavik Forum a couple times. That's a friendly space in that it's women political leaders. They're incredibly interested in this work. And so it lands well. I think it lines up to other investment arguments around human capital development. Another area where we're coming back to this is through a World Bank funded project on healthy longevity. And so making the case that without thinking about the significant roles that women play in terms of their contribution to unpaid work, it's this risk to the upfront investment in human capital, because women are exiting the workforce at the key time within which they're supposed to be deploying the human capital that we invested in an early age. And so if we are to realize the benefits associated with that childhood investment in education, we need to think seriously about the unpaid work, because it pulls individuals out of the workforce. And so that links in part to childcare as well, because you're impacting them at the earlier stages of their human capital development. Preferences is interesting. And I mean, I think this is an area that I'd love to spend a little bit more time thinking about, because while it's not an area that I've worked on and can speak to directly, anecdotally, and I think in terms of other work that I do on access, the issue around patients' preferences for the type of healthcare provider they're interested in, the model of healthcare, I think there's scope for some of that work to connect in more interesting ways with health workforce planning. I don't know that we actually integrate patient preferences for the sort of healthcare provider that they want enough within health workforce planning. And so I'm not familiar enough to say if it's happened or not, but I think it's an interesting potential. I think that I wanted to make one point about feminized work, and Michelle, you could speak to this as well. I think what we see in some areas, and community health is actually an interesting example, is that the wage and the value for the work sort of starts to go down as the workforce becomes more feminized. There's examples with community health work where in countries where men have entered the work, they're more likely to have a wage attached to that, and the value of that work starts to increase for community health work in particular. And so while I'm not making a case for moving away from a feminized workforce, I think we have to think seriously about the social norms that go into the ways in which that work is valued, because that then influences in very clear ways, as we sort of see with the example of males entering community health work, that it happens in a way that we're not seeing with other areas of feminized work. And so that social norm piece, I think, is very key. Now, I have not answered all these questions, but I'm happy to address others as we continue the discussion. I think we'll have some more time later on in the session.
And we have thank you, Bev. We have our coffee break, which is just outside the venue here, and we'll convene back here at 3:15. So that gives us a nice time to relax and carry on the conversation.
So welcome back, everybody. So we're moving on to the second part of the learning session. It's going to have less data in it, because actually part of my objective is to recruit more people to work on this topic of gender and health financing. It's quite a small field, and definitely has had less interest than the health workforce area, which is kind of interesting, and we can discuss and think about why. Next slide, please. So health financing is obviously about how you raise and how you allocate money. It's very much about distribution. It's very inherently addressing issues of power. And so I think it's very relevant for gender. Typically, however, as health economists, we've worked very strongly with sort of socioeconomic data when we think about disaggregation. We often look at location as well. So we typically look at kind of rural-urban patterns. But gender is surprisingly absent, even when it could be there in the data sets. And I'd be interested, and I'm sure Elaine will have thoughts as well about how we use data. But yesterday, for example, we were in a session on financial protection, and we have every 2 years this UHC monitoring report, and we have data about all sorts of variables there that are really important and used all the time in policy analysis. And I felt sex was really notably absent. And yet we know that is in the survey data that's being used to generate catastrophic expenditure, for example, is impoverishment, out-of-pocket payments, all those things that we track and care about and are important for policy tweaking. So I think for today's session, it'd be really interesting to get your thoughts in the room about how we build gender in more to our way of thinking and our analysis. So back in 2015, we had a webinar called Minding the Gaps, where we looked at health financing universal coverage. and gender. We highlighted gaps in research. We talked about some of the areas where there is literature. So the user fee literature has gone a little bit into some of the gendered issues. To some extent, discussions around health insurance, which we touched on earlier in Asha's session, are there. There's also some discussion around sexual reproductive health, how far it features in health packages. But that's kind of, those are the main pockets of discussion, and there's an awful lot of gaps. So for today, it's nice to think about, have we moved on? Have we made progress? And if not, how can we generate more momentum? So next slide, please. So just to give you some examples of the gendered questions in the article that came out of that webinar, we tried to think across the health financing functions, what are the things that we should be asking more routinely? And so not to run through all of them, but just as some examples, you know, who's paying for healthcare, how's it changing, how fair are those contributions? Again, thinking of that with a gender lens. You know, who's carrying the burden of paying? So some of the analysis of progressivity, but with a gendered approach. And what's the implication of changing our revenue sources? One of the issues, as you all, I'm sure, very aware, is that the intra-household dynamics are very important to financial access and addressing financial barriers. But obviously, many of the surveys and analysis focus on the household. So are we getting at those issues of who makes decisions and who has access to money, and how that affects ability to pay for healthcare, for example? And how are we distributing public and private funding? Where's it going? And how does it meet the needs of different population groups? So just some examples. And again, if any of you are working on any of these, I'd love to hear, because when I look at the literature now, I still find it quite thin. But maybe we're missing, or maybe there's a lot going on that just hasn't made it through into publications as yet. Next slide, please. So risk pooling, obviously, who's covered under different risk pooling mechanisms is really critical, but also understanding about protection against shocks. So this question of access and financial protection. What kind of programs are being prioritized under purchasing? We've talked a bit about gender sensitivity, but what are gender sensitive services being purchased? And how are our provider payment mechanisms incentivizing high quality care for all sexes? So understanding different preference patterns, for example, which again, we touched on a little bit in the previous session. Next slide. So the final set of questions that was highlighted, and this is again just back from that same paper, is around resource allocation. So looking at allocations, different areas, also different services and schemes. Are the benefits packages well understood? So we know that there are lots of issues of transparency, predictability, and that affects people's ability to use services. So issues of awareness and stigma, and how those are addressed by different financing schemes. And of course, utilization patterns, absolutely critical to track fairness in terms of addressing different barriers. But finally, also the health financing governance, and this comes back a little bit to what we were talking about earlier in terms of health committees, for example, but how are different genders represented in the health financing structures? So finance, for example, facility management committees allocate and manage resources, you know, who's in them, and how does the regulatory system ensure fair access and quality of care for all genders? So non-exclusive, but just a kind of trying to prompt more work in this area. Some thoughts about a sort of research agenda setting now. Next slide. So when you look at the literature, there are some topics that come out in terms of vulnerabilities. And often this is looked at sort of across the life cycle. As the example on the right that came from a paper I was involved in with Volosny, Michelle and others. So one theme that's quite clear at the moment is around issues of access to cash. So any financing scheme or policy that involves out-of-pocket payments is going to be challenging, particularly in where you have social systems which make women's control over cash or their decision-making more limited. And a lot of the literature on this comes, so maybe I'm sure our colleagues will pick up on it, because quite a lot of the literature on this comes from India. And it's quite strong in showing that it isn't just about socioeconomic differences. In other words, even women from, wealthier groups, better connected groups, they still have gender barriers in terms of their ability to make decisions about use of services and expenditures. There's also the higher caring responsibilities, of course, differential health needs. Of course, we know about sexual reproductive health, but also relating to aging, for example. And then in terms of entitlements, the issue of the kind of employment patterns that women face are often directly affecting their coverage with insurance schemes, for example. So having more informal and insecure part-time employment typically affects their entitlement to protection. Also wider sociocultural barriers. Can they move? Can they get into facilities? Are they able to make choices? And as I highlighted, this issue of power within the household and where you have rationing of resources, whether girls and women get discriminated against. So those are some of the vulnerabilities, and they imply certain design features around how we set up policy. So next slide, please. So some of the lessons that are coming out of the limited literature are still quite important to highlight. So one of them is clearly around the role of public investment. Public investment anyway, we sort of encourage in the health sector, but it's particularly can be pro women and girls because of the kind of needs and so on that were highlighted on the previous slide. But also the importance of decoupling your entitlement from financial contributions because of the way that women are often discriminated against in the workplace or play different roles. And we've talked a lot about the caring roles, the unpaid roles, etc. before the break. Having a package that covers the whole household so that you don't have to choose between your household members because of this intra-household, this, power and perception differences, but also covering the whole of the life cycle. Also gender sensitive care packages. So not just sexual reproductive health and maternal care, but also looking at how your provider mix encourages women to use and proactively addresses the sociocultural barriers that are known about in your context. So there is some literature on demand side. A lot of the voucher schemes, for example, have been targeted at sexual reproductive health and maternal health care. And we know there are lots of challenges about how those work and whether people uptake them, for example. There's still a lot of stigma issues there, but that's an area where there has been quite a lot written, not specifically with a gender lens, but certainly in terms of specific packages of services. And maybe Volosny will comment on those more, but also ensuring human rights are protected. So there's been a lot of concern about medical imprisonment, for example, countries, and I'm particularly aware in West Africa, but it may be much more general, where people are held until they pay their bills. So there's actually sort of kidnapping of babies type approach, which is clearly totally unethical. And then this issue of looking at intersectionality. So not just taking poverty as your sort of indicator of choice, but thinking more generally around the different barriers. And we've, I think, had quite a lot of examples of those already today. Oh, somebody's agreeing at the back, hopefully. Particularly in countries where the private sector is a dominant provider, we also have to think about policies that are very specific to either incentivizing or regulating private sector providers to ensure that you don't have discrimination. And this issue of sort of abusive care, unnecessary care, inappropriate care has come up quite strongly in some of the literature. Again, not necessarily addressed specifically from a gender perspective, but actually when you look at the services, a lot of them are. A lot of them are around cesareans or around, unnecessary treatments during deliveries and so on. So there's something there that, again, this isn't so much health financing, but the way there are high financing tools to use to address it potentially. So there's some cultural things happening in facilities which often are damaging for women. Next slide, please. So this one I've just put, it's probably not very easy to read, especially if you're sitting at the back of the room, but I thought it was interesting piece of work because it's an attempt to have a kind of scorecard that brings together some of these different features so that you can look in a kind of snapshot way at what data is telling us about how health financing and some health system and actually some broader features are serving women in a given context. And it's not published yet, but it was developed by Katie Bullman and her colleagues at Genesis, and it's a little bit of a thought piece at this stage, but I'm interested whether people think it's useful. So on the kind of raising the money side of the equation, it tries to look at some indicators that feed into that, like workforce participation, for example, unemployment rates, again, in a male to female type way. So looking at differentials. And then, yeah, then when you come to this kind of allocation area, looking at things like proxy, so in this case, they've used reproductive health as a kind of proxy for gendered services, but looking at it as a proportion of the general health expenditure. And equally on looking at, for example, budget execution. So how well is the money being used, but trying to break it between general health expenditure and more gendered services like RMNCH. Gender-based budgeting, so it's sort of following the line across, and then looking at, in terms of the kind of distribution and the equity of the spend, again, looking at ratios and whether we can break down things like catastrophic health expenditure by sex, looking at whether we can look at out of pocket, again, between different types of services, and equally other areas like benefits incidence analysis, which we don't typically break down by sex at the moment, but potentially could if we thought that was a useful thing to do. So it's trying to bring that all together on one slide for one country, or you could do it at a district or state level, obviously. But then at the bottom, you've got some more kind of general indicators that are important, like pay gap and ability to determine, to make decisions about healthcare, for example. So these are your kind of more general sort of female empowerment ideas. So the idea here is that, and we were talking about the importance of measuring and using data to trigger change, is that by putting these kind of things together, we can provide a snapshot which helps us to identify where are the blockages, if you like, in the pipeline that need addressing, and what are the critical factors in enabling women to have fair access and utilization of healthcare. Next slide, please. So it's under development, but I've been interested to hear where you think that sort of works, or it's less useful. So not to go into detail here, because we talk about some of these in some of the other sessions, but just to say, of course, health financing, like all systems areas, is very interconnected. So when we think about UHC, we also have to look at all the other building blocks. And we've talked about some of those. We've talked about leadership and governance, for example. We've talked about HRH. This issue of violence and discrimination is a really key one that we were discussing before the break. Next slide, please. Supplies and infrastructure. So when we look at and we were talking in the session yesterday about the out-of-pocket payments, so something like 2/3 of out-of-pocket payment is spent on medicines and commodities. So a key driver of the household spend and therefore of the kind of cost burden also for women is coming from that area. So looking at the availability of those, are the appropriate supplies for kind of key services, a choice in relation to them. Basic things like water and sanitation, we know, are really important in women's use of facilities, often absent. So in other words, a kind of plea really to look at the system as a whole and how it interacts. And then, of course, finally, data. I think we're all talking about data, but we know that there's a lot that is not measured, and that even the elements that are measured are often not disaggregated, and that kind of monitoring and evaluation component is not very proactive at looking at these distributional issues. So all of them are really critical. And highlighting, yes, the materials that Asha was talking about earlier. We're part of a research consortium that fed into RINGS that has a lot of tools, including gender analysis, very practical, easy to use, and very helpful for research community. So do have a look at those. Next slide. This I put up just to illustrate, again, a slightly different way of conceptualizing it, but it's looking at the kind of care trajectory. So somebody, the question of whether, of what level of need you have, whether you perceive it. So it's a bit like the delays model in a way, you know, deciding to seek care, actually reaching it, being able to use it, and then your kind of outcome. So it's thinking of it in that pathway and kind of mapping onto it the different issues that come up, which again, all have different policy implications. So they're not easy to read because it's white on yellow, which is a design problem. But this is all about your sort of, your perceptions and your awareness, you know, whether you can, I can't even read it from here. Dreadful. Okay, even I can't read it. I'm standing right in front of it. So we'll share the slides if anyone's interested. Again, so the bottom line is really looking at the kind of individual or household level factors that affect it, and the top line is more your classic sort of supply side. So, you know, whether acceptable, you know, available, whether you can afford them, and the kind of issues that affect your quality of experience when you get that, and quality of outcomes. But it's another important phrasing, which again takes a gendered approach, I think is quite helpful and brings it all together. Next slide, please. Yeah, just finally to highlight a few of the sort of data sets and sources of information for people who are interested in doing more sort of disaggregated and sort of gendered analysis. I think we're probably going to put our slides somewhere where people can, anyway, I think we're going to make them available at the end. Next slide. So I think just a sort of final observation is that there's been some interesting thinking being done. I still think there's very little coming through to the publication side. We're often having conversations in a slightly siloed way, where we have people thinking about gender in one area, we have people thinking about health economics in another, we have people thinking about obviously women's health or whatever. We have a lot of different interesting conversations that aren't connecting very effectively. So interested in your thoughts about how we could take that forward. And just to hear about work you might be doing, what you're learning that's new, because a lot of these ideas have been around for a while, and we need to take the kind of debate and the policy implications of the debate forward. And how do we get more momentum? It's very hard, probably quite hard to get funding in this area, I'm guessing, is one of the factors for research. But any thoughts on sort of good ways of mobilizing? So I thank you very much, and I think I'm handing to Hélène.
Thanks a lot, Sophie, for the great overview. I think you provided a very interesting health financing perspective to the discussion, right? So it's quite a different perspective from what we heard before. So I'm coming from the WHO. I work in a team where we develop guidance and norms and standards on health financing. And so the first kind of complementary point that I wanted to make to Sophie's presentation is the fact that gender has not been part of the thinking when we've been developing such guidance, guidelines, and for the past years, or I don't want to say decades, but it may be like that. And so I'm very happy to be part of the session and to be part of the organizing team, because I think it's really a milestone for us to start integrating more explicitly a gender dimension into the frameworks and guidance that we develop on health financing. So that's the first point that I just wanted to acknowledge. I come to this discussion from, I would say, really an outsider perspective. I'm not a specialist on gender at all. I worked on public finance and public financing arrangements. But as said, I'm part of this team. We're working on guidelines, and I found it very important that now we do incorporate this dimension. Related to that, I think incorporating gender into those frameworks is a challenge to us, is a challenge because I think it means to somehow revisit some of the traditional approaches that we have been defining or that we have been supporting in countries. This morning, I was in a session about introducing social health insurance in low and middle income countries. We know that this instrument has many benefits, but it has also some limitations for several health financing reasons. But we've also learned in this session that it may not be a good option from a gender perspective, okay? So with that in mind, what it means to us from a health financing perspective, it means that we need also to reconsider and rethink those tools and instruments that we, and the advice we provide to countries with this new dimension in mind. We know now that there is a problem in terms of the affiliation to insurance funds. We know that maybe there is also a problem in terms of the reimbursement arrangements. The father or the man or the husband is likely to be reimbursed potentially for some expense that he didn't even pay for, right? So several issues from a gender perspective that have not been considered and registered so far, but I think it's really high time for us to integrate those perspectives. So really a need to include that more explicitly and potentially to reconsider and review some of the traditional instruments and approaches that we've been not advocating for, but providing support on. The second point that I would like to make is regarding data. Yes, Sophie has mentioned it, and I think I will even would like to challenge a little bit more, even conceptually, the way we collect and analyze data. So I think the example of financial protection is very eloquent. So the level of analysis. So first of all, the level of collection and then the level of analysis is the household. And I think this notion of household is increasingly problematic in itself, right? So we know that demographic and health surveys do collect data by families, by households, okay? But now hearing you guys, I'm increasingly convinced that this notion has many limitations and is not gender responsive at all by definition. It's really a dramatic challenge and an issue, I think, for our sector, because all the survey systems and the data we work with are really fundamentally structured by household, right? So it means a kind of radical and systemic change in terms of how we collect and then analyze the data. But hearing from you, it seems that we need to take this problem really into consideration. It's really the basis of how we monitor financial protection. It's monitored at the level of the SDGs, for all countries of the world. So it's not something marginal. It's really something that is driving the way we conceptualize and monitor progress towards universal health coverage. And this progress is monitored at the level of household. So I don't have a magic solution on how we can resolve that, but I can reassure you that from a health financing perspective, I will put that on the agenda of the team, and I'm sure we will have some very agitated discussions about how to take this into consideration. Thanks again. Shall we take some questions? Sorry. Yeah, please. I know that some health financing people are in the room, so you may be interested to comment on that. Yes, please.
Thank you for the presentation. It was a meta-analysis. It was fairly amazing in every way. I'd like to just comment, however, on what was just said, because I also found it, gee, what a light bulb went off in my head about the issue of analysis taking place at the level of the household. That would make sense. As economists, that's how we were trained. So this is going to be tough. And I hadn't really thought about the implications of that. But clearly, there has to be some way, given the gendered analysis that we're, working on and that we're learning about, there has to be some way that we can not leave aside the household, because I still think that's tremendously important in terms of social relations and understanding material conditions. But maybe in financing, taking the detailed information we've gotten about the gendered nature of healthcare financing, how we need to improve, and somehow using the old toolkit of mainstream economics, incentivizing in some ways the money that goes into the household so that it becomes under the control of the women. That's the only thing I could think of, but thank you.
Let's take a couple of questions. Thanks so much for that overview. Meta review is a very useful way to characterize it. So we're starting to do some work in the cancer space to look at the share of household spending associated with managing cancer in low and middle income country context in particular. And with breast cancer, as part of the review for this work, there's actually been quite a bit of work in India that's looked at intra-household decision-making. And so, you know, back to your point, this opportunity to even experience out-of-pocket costs is not equally available to members within the household because of the ways in which decision-making happens. It's quite qualitative. And so we're starting to do some work that will quantify this. I think there's some use in looking at, you know, extended cost effectiveness analysis as a framework that's trying to look broader and pull in non-health outcomes. So pulling in financial risk protection. The movement in that framework is to actually disaggregate by sex as well, so that we understand where the financial protection gains will be made for particular conditions, and then to understand that by pulling in, you know, it's male and female at this point, but some of the work actually has a gender dimension into it. So again, that's starting to look at the non-health benefits, the financial protection benefits associated with particular investment decision making, and we're starting to see some bridging of gender incorporated. But again, it's not completely mainstream just yet. But I thought I'd raise those two examples.
Thank you. Robert Colasar with Palladium. So first of all, thanks for the organizers of this session, and lots of interesting information being shared. Very much appreciated. So I had kind of two thoughts. One is just on the disaggregation household analysis side. And one thing, and it's kind of just a small point, but I think that it's critical to disaggregate households by female-headed households, single female-headed households, because that's typically where you're going to find the biggest disparities. All of the health financing indicators, catastrophic, and then if you can sub-aggregate it, usually those are the women that are in the poorest or the households that fall into the poorest quintiles. Regardless, the impacts are going to be even larger. So just that one point. The other thing is something that I didn't yet see, maybe this is coming in the next part of the session, is a focus on looking for I guess kind of stimulating research, which definitely is thin in this area, in terms of kind of helping to quantify and highlight the issues. And I think that's very important. However, I don't think that that's the whole pie, because I had the opportunity to serve as an embedded advisor within a Ministry of Economy and Finance for several years, working on advancing UHC issues. And at the end of the day, when you present all of the evidence on, you know, catastrophic expenditure or inequities and vulnerable groups and so on and so forth, you're talking to a bunch of, I would want to say predominantly 90+% male economists and accountants, right? And so they want to balance the books and they want to know, how is this going to help them achieve their ultimate goal, which is economic growth. And so I would argue that there has to be another agenda that is linked to kind of what's already been laid out in the most recent slides, that is about the investment case. So clearly identifying, here are the issues, yes, this is unfair, but our argument is about if what are you missing out on economically for your country if you do not take action to reinvest in policy change in these areas. And so I think that is where my experience has been where you're able to get traction and attention from the people that actually are the people who are going to make the decisions. Otherwise, I think there's a limited audience, right, in terms of just leaving and identifying if these are inequities and it's an unfair situation. Thank you.
Sophie?
Yeah, thank you. So, I mean, just reacting, and I'm sure, I mean, others and Ellen may want to add as well, but just reacting to that last point, I think it's really interesting what moves, what makes change, what brings about change. And I guess we have to tackle it on different levels. I mean, I've seen a qualitative research that was based on the story of one woman bring about a big impact in a country where, you know, it was presented to the president. It was a very emotional story. So I think different kinds of evidence work for different people. And I'm not sure investment cases always work. I mean, yeah, obviously, if your accountants have the power, maybe, but do they? So, so yeah, a bit of sort of power analysis is obviously required when we think about how we present our material. I know it's a bit of a dystopian vision, isn't it? World run by accountants. But sorry, apologies to anyone in the room who's an accountant. Yeah, so I think when we do political, you know, economic analysis, we think about interests, you know, but we also think about framing, which is really important. So it's like how the agenda is set. And obviously people's position. But yeah, I think there's been a lot of work, and also in the health workforce area where they've tried to say, look, this is the economic case for that. You know, this is what the health workforce is doing. It's a massive part of your economy. You know, think about it in a different way. Think about it as a productive sector, as opposed to a kind of consumption, etc. So I think there has been interesting work done to try and use more, sort of economic arguments, and certainly for health in the same way that if you're not looking after, you know, the majority of your population, which is what women are, then you have a huge economic problem. So I'm sure we could do it better, but I think we have tried to use some of those tools a bit more. But at the same time, I think some of the emotional and more story-based tools can also work quite well for some people. I don't know if you want to say more about the house. I mean, I think, yes, and female-headed households, completely agree. And I think that kind of data is often presented. I mean, just yesterday, and when we were looking and doing a deep dive into Uganda, obviously one of the areas, female-headed households were coming out as one of the most sort of severely affected groups in terms of catastrophic payments and so on. And that tends to get drawn out. I don't know if we do it as well as we could. Helen, I don't know if you want to add.
I think I take the point that you've mentioned. I don't think we need to completely shift from a household-based perspective to an individual-based perspective. I think we need to combine both. My point is that having only the perspective from a household view as probably not comprehensive enough or not gender responsive enough. Just one thing to reflect on what you've mentioned in terms of the investment case. I tend to agree with Sophie as well. I've seen also that some policies do exist. We have some tools. I can just take the example of gender-based budgeting. It was mentioned here. So it's a way either to tag gender-related activities in budget, or even to formulate budgets according to specific activities and programs that do respond to gender-related issues, right? So the tool does exist to make the budgets being more aligned with the needs of certain categories of the population. So, but the problem is that the tool, it's not that the tool doesn't exist, is that the tool, as you said, probably the tool is underutilized by government and in government budgets, right? So it's more an idea to, I think, try and mainstream what we know works. And in terms of convincing finance, I think they are very familiar with this tool. It has been promoted by the World Bank, by the IMF, so it's gradually implemented, but I think it should be, yeah, accelerated much more.
Yeah, I don't have anything to add except it brings us back to women in leadership positions, because it's who are you presenting it to, and kind of what's their interest and framing and their empathy circle or whatever. So that's perhaps also an area beyond tools, is having more women who are sitting in the finance office or whatever, the infamous accountants. Feminized accountancy. Any other questions? If not, I think we pass on to our next session.
Maybe just in terms of next steps, just thinking loud in terms of, I think first, we need really to take into consideration this gender lens into the frameworks that we are developing in WHO and with others. I think this is really an important point, that's not been there, so it should be there more explicitly. I think it's one. So there is more work for us in terms of what does it mean exactly to unpack and then integrate this new dimension into the thinking. Second, I think, Sophie, you've started to review the issues and then the tools and some potential remedies that we do have. I think probably there is a need to update this base, because I think new approaches, especially on the demand side, have been tested from a finance perspective. So what has worked, what is working less? So I would say let's do an update on that. And third, let's work with colleagues that are more closely engaged in DHIS, so the data systems that we use in health financing and to monitor financial protection, to see to what extent they can also try and think about how to incorporate this, I don't want to say additional level, but this complementary perspective into their approaches. It's a huge debate, and challenge technically and conceptually. We will not resolve it here, but I think it's our responsibility to bring it to them. So maybe with that, I'll stop there and pass the floor to you. Thanks a lot again.
Thanks. So this session we'll talk a little bit more about one specific area of health. I think gender is so inherent that it's fairly obvious for us who work in SRHR that we can't talk about sexual and reproductive health without acknowledging the importance of gender, but also acknowledging the importance of rights. It's intrinsic to it. And I think it was, Helen, you mentioned the SDGs. When we talk about health, we talk about SDG 3, we talk about universal health coverage. When we talk about sexual reproductive health and rights, we're talking about SDG 5 and gender equality. So I think this is an important area that kind of illustrates some of the concept and some of the discussion earlier, particularly around gender power relations, which Asha described really upfront. We talk about disaggregated data. We talk about health financing. And I work in the Department of Sexual and Reproductive Health and Research in WHO. And I come from a health financing and health economics background, but it's great in that recognizing how important gender is fundamentally to that area. Fabian, the next slide, please. You can move to the next one. So we'll do this presentation or the session right now in two parts. I thought I'll start with just a very broad framing of sexual and reproductive health. And if it's obvious to some of you, then I'll quickly skip through it. And then Raj will talk about some of the actual data and some of the questions that we can be thinking about from a health economics perspective that are often quite, right now, kind of not, but we do not have enough research on and enough evidence on. And she will draw on that from her own research in India. So sexual and reproductive health, as we know, describes the state of physical, emotional, mental, and social well-being in relation to all aspects of sexuality and reproduction. And it's very much across the life course of all people, and very much takes into account the questions around rights and rights in terms of bodily autonomy and integrity. Very much also questions around decisions. So the question around gender power relations is very much integrated and well recognized within that definition.
is who holds the resources, who makes the decision, who has voice. And when we talk about sexual and reproductive health, we talk about a comprehensive range of sexual and reproductive health services. These include maternal health, from antenatal, postnatal, perinatal care, to include reproductive health cancers, breast cancer being one of them, sexual health, comprehensive sexual education, and of course, unsafe abortion. And I won't go through the whole list, but also including is the question around gender-based violence. So gender and rights are very much cross-cutting. Can you move to the next slide? So as noted, gender intersects all aspects of human life. This is particularly, especially important in the areas of sexuality and reproduction, but also when we speak about men and boys, women, adolescent girls, transgender and gender non-conforming youth. And what we've seen, and which has been quite made more prominent during COVID, of course, are the gaps in access to sexual and reproductive health services. We saw during COVID, there were disruptions in family planning services, disruption in access to family planning commodities. This contributed to increasing number of unintended pregnancies. We also saw an increase in gender-based violence. We also know that more than 500 women and girls lack access to services around their menstruation. And these are all important SRO sexual and reproductive health gaps, but the underlying drivers are often embedded within the health system. If you can move to the next slide. And the gaps in access, one is related to overall gaps in gender in terms of health financing, both at a global level, also at a national or a domestic level. And some of these are not specific to sexual and reproductive health, but in terms of broader advocacy for more domestic funding is an important one. If services are not included within health benefit package, we know, then there's a much greater opportunity for them to be, for those to be borne by households or by people through out-of-pocket payments. Gender norms, stereotypes, and inequalities also impact on access. The other important issue, and I think particularly for sexual and reproductive health, well demonstrated through access to safe abortion services, is the role of restrictive laws and policies. And this, as we know, is played out in many, many contexts. I was at a meeting earlier this year in looking at access to services and the role of parliamentarians. One of the countries, like Malta, has access or universal health coverage, but access to safe abortion services are not available. So women will have to travel to other countries to be able to access care, and which of course has implications for affordability. Do they have access to be able to pay for a plane ticket? Who will receive them on the other end? So it has all sorts of important implications. And the health system's constraints as well, Sophie described them importantly as well, questions around availability of medicines. We know that there's a much increasing focus now on self-care. But if available medicines for a self-administered abortion are not available in a country, if it's not available on an essential medicines list, how then are people going to access it if it's not included within a health benefit package? So these are all important questions. Other issues around affordability has been raised, and Raju will speak to that as well, but also questions around purchasing of services. We speak about, increasingly there's more focus on strategic purchasing, and the question for us would be is what is the role of strategic purchasing to influence the behavior of providers, and the role of incentives in terms of encouraging providers to provide better quality of care, etc. I have here on the slide the question around, or the topic of C-sections. We know that in some countries, there's an oversupply of cesarean sections, and there's been a lot of research that's looking at why is that the case? Is it because of the private sector? Is it because of the way providers are incentivized? Is it because of the the legal ramifications. And in other instances, there's an undersupply of cesarean sections, which of course contributes to maternal deaths in many instances. What is the role then of purchasing in those instances? Next slide, please. So I'll now hand over to Raji.
Hi, very good afternoon. I hope you're not feeling too cold. I am. You are? Okay. So let me warm it up a bit. And my name is Rajalakshmi, and I'm from Chennai, which is the capital city of Tamil Nadu in the southern state of India. I'm a health system researcher and a social scientist, not a trained health economist, and probably that gave an advantage to look at the publicly funded health insurance scheme implemented in my state. And looking at it from a gender lens, I could pull out a few insights that I thought I could share with you today and reflect along with you. And I would like to also place on record my gratitude to WHO for inviting me here. And as a woman who has come out of formal sector to informal sector as consultant, it means a lot to be invited here. Right. Beyond sex disaggregation of data, it's been touched a few times before by the other speakers, but really now we need to include the non-binary in all our data collection instruments, because if they are not visible, we are not going to know the impact of any of the interventions by the health systems. It is needed. It's the first step. Sometimes it alone can be transformative. It can be an eye opener, but one cannot stop with that and say, yes, I've done my bit for gender. No. Because then what are the patterns, gendered patterns, that are giving rise to these numbers? So there are stories behind numbers which we need to capture, which can be done through application of gender analytic frameworks. Though in the beginning, it may sound a bit artificially that you're trying to look at the frameworks and see where it applies, put them in boxes. It is nevertheless worth an effort to look at some of the gender analytic frameworks and see where they can meet with the work that you're already doing. So, for example, how do you do gender analysis if you're taking only women's sex-specific conditions, say hysterectomy or cesarean? Can you do a gender analysis because you don't have a comparative group? But to understand that gender works in health systems, in state policies, in markets, in labor economics, how health is financed is what we want to capture. It's those gender power inequalities that give rise to patterns of differences in outcomes across the gender that we want to actually capture. So we are not looking at purely at men versus women or versus transgender, but we are looking at how inequalities are operating in a way that certain outcomes are showing up and certain others are being missed out. So I would also look at, I'm sure you would have heard about Wagstaff's health, vertical and horizontal health equity. So for women, it's an integration of both horizontal and vertical. So often times we find researchers engaged only with one and not the other. For example, cardiovascular diseases. Now there's growing evidence that women are equally at risk for CVDs, only the type of presentation and their care seeking and how it's being treated by the health systems is totally different, giving rise to, a certain kind of numbers. But if we don't do gender analysis with the understanding of gendered patterns operating irrespective of whether we are seeing a male or a female as benefiting or in the health workforce, we are going to miss out on a lot of those dynamics from our research. Next slide, please. For example, in my study, initially it was hospitalization rate and health expenditures for women together for all kinds of hospitalization. But when I disaggregated maternity-related hospitalizations and expenditures, I find new patterns. For example, often, I think in the morning also somebody was saying the health insurance parity, gender parity is not there. Women are charged more because there is assumption by the actuarial analysis of insurance companies that women seek healthcare more for maternity related and childbirth related causes. But if you disaggregate maternity, the hospitalization rate is equal to that of men from the state that I'm coming from. So that means that they are equally getting hospitalized for non-sex specific conditions, which is totally getting missed out from the discourses. And also the share of the private sector for women's hospitalization increases if you remove maternity, because maternal and child health is heavily protected by the state to cash vouchers, etc. But the non-MCH kind of conditions, women have to pay out of pocket. So this comes out when you disaggregate not just men, women, but also if you have the right understanding of what gender power is all about, then you disaggregate within women, subgroups, caste, race, or based on their age. The elderly women's vulnerability often comes out when you use both an intersectional analysis of age and gender. So the sources of financing, for example, goes up for women in terms of selling their assets or reducing their consumption. This picture wouldn't have emerged if maternity was not removed. So the NSSO, which is the national level survey done in India, in this round did not do this. But if you find the 75th round, they have picked this up and they have started analyzing, removing the maternity related conditions to understand women's vulnerability for horizontal healthcare needs. Next slide, please. So sorry, I'm going to apologize for, I think you were the one who said, don't tell what should health economists do. We are sitting out there. But, I thought it's important to have some key takeaways. So whatever I felt could be done, can be done, is that to understand, we have to go beyond just mere sex disaggregation of data, look at those gender power relations which are causing these patterns. And I would say to err on the wrong side. Maybe all differences are gender differences and no pure sex differences. And then you strike out any causal factors that could not cause a gender-based difference, but only then it can be attributed to sex difference. Because I'll tell you a World Bank document which talked about the high rates of claims for cardiovascular diseases from the insurance scheme just wrote it off by saying this is because men are more prone for CVDs. That's it. But how much, okay, even if there is medical evidence to speak to that, how much of a difference is fair? How much of a difference is avoidable? Therefore, the unfair and the avoidable differences between men and women is what we need to quantify. There could be a difference, but is that much of a difference justified, or are there other systemic factors and social determinants which are actually exaggerating that particular difference? And to apply, for example, horizontal and vertical health equity is a very important concept that we can hang on to when we do our analysis. Next slide. The second issue, so I thought of presenting three important issues where gender and health economics can intersect. Second is relying on household. I think it's come up on a big way, but I'm going to give an example from my study of how CHE was calculated, which totally put under carpet what the women's experiences were. So CHE is catastrophic health expenditure. I'm sure many of you would know how it's calculated based on an arbitrary 40%, 25%, depends on the researcher, which cutoff point I can use, and the overall household income or consumption and the overall health expenditure, and you try and derive it and decide whether this household went through a catastrophic health expenditure or this household didn't. But it assumes there that all the resources in the house can be equally accessed by everyone, which I think we all know doesn't happen. And therefore, the whole calculation of CHE, does it account for intra-household allocation of resource? I'm not here talking only men versus women. If there is a mother-in-law and a daughter-in-law, and there are two daughter-in-laws, in my study, I found it was the youngest daughter-in-law's jewels that go to the mortgage to finance the health expenditure of the father-in-law. It's not the first daughter-in-law, it's not the wife of the man. So within women, not all women are equally placed and cannot leverage the fact that that they are men or women, but the intra-household differences were totally missed out. The next slide. So this is a picture of one of the households that I did in the survey. So this is how, if you see in the same household, there's a 42-year-old male who's an auto rickshaw driver who's earning 8,000, has a few assets. The house is in his name, the auto rickshaw is in his name, and he has a two-wheeler, and he has a health insurance card. And for a cardiovascular disease, although it didn't pay fully for his treatment, he was able to use that card. Still, his expenditure alone would be counted as catastrophic health expenditure. Whereas his own mother, who was a 64-year-old widow, who was just a domestic worker and had 2 goats. This was, my study was done in both rural and urban areas, impoverished areas. Now, for a diabetic gangrene, she decided to go to the public hospitals because she was very well aware that she cannot afford, or she didn't want to use the family resources to go to a private hospital for care. So the rationing and the bias comes in, and sells 1 goat because she has to go up and down for 3-4 times. It costed her some money. But if you were to assume the household had only that female there, the woman there, this household will not be considered as a household with catastrophic health expenditure because your denominator itself is so low. So your allocation for healthcare and health expenditure being so low itself removes you from being counted as CH, a household experiencing CHE. But if they were in the same household, yes, only because of this case and not because of that case. So how many households are experiencing? So what is the threshold for a woman to tip off and sell her assets and become impoverished, consume less, stop the education of a girl child in the family? And what's the threshold for a man can be very different. And between men and between women in the same household could be different. So next slide, please. So what we could do is to try and see, first is to recognize that there is differential spending, differential income within the same household, and differential impact of health shocks. A health shock, how it affects a man or a woman within the household is going to be very different, again, based on their intersectional positions. And if we were to develop new econometric tools to capture this, that would be fantastic. And there's one work which I found from Indrani and Joe of 2013, where they are not just taking only income as the indicator, but they are looking at social status and education and developed a composite index and then try to understand CHE over a continuum. So there's no 10%, there's no 20%. You could have a different cutoff for different members of the family, and therefore you can then bring in the intra-household allocations into picture. And I think it's the most important thing here to understand the difference between access and control. I had also wanted to respond to, sir, your comment to this on female-headed households. I sort of beg to disagree because often female-headed households are able to make independent decisions because the woman is the head and she can leverage the fact that many schemes, social protection schemes, are explicitly addressed to female-headed households. But it is the women within a heteronormative family often not able to negotiate and bargain for accessing healthcare. So let us not again just make it as a tick box exercise to do gender analysis by including female-headed households, because you're talking about how many women can bargain, negotiate, and use the household resources to say, yes, it's time for me to get hospitalized. Somebody else take care of my unpaid care work. Because in the study that I did, many women, in spite of being medically advised that it's time to get admitted and undergo a surgery, are not able to because they cannot find another female replacement to continue the household chores and care work for the children and for the elderly, and they're just waiting for that to happen. So if only social protection schemes could compensate for an attender within the hospital, and the hospitals in my state have this policy. If it is the male ward, a woman can go and attend to a male. But if it is the female ward, only another woman can attend to the hospitalized woman. And I saw so many households where the women are not able to bring in another woman to take care of her within the hospital settings. And that is delaying treatments for a long time and having healthcare outcomes. So these are some very grounded, nuanced findings, but that speak to kind of policy level, changes that we need to work and advocate for. Next, please. I think that's the third. One thing also is in my work of a literature review of UHC schemes is that they are often clouded in gender neutral language. Households, distress coping, healthcare expenditure. Where are the women in this? I mean, it takes a while to even understand that to actually call out to them as gender blind requires a mix of methodologies. I urge health economists here to also employ qualitative research methods. It could enrich the findings that comes from quantitative methods. And you will find, if you can, all of you think of one LMIC that you are most familiar with. Do you think the essential benefit packages include access to abortion services? If it's not, then it is a gender blind UHC. Do you think UHC plans, for example, have relaxed the documents required by transgender to get enrolled in health insurance schemes, or do the packages include gender affirmative treatments? If it's not, then we know that the UHC scheme is gender blind. And do we factor in the unpaid care work that women do day in and day out in the way the health insurance schemes, publicly funded health insurance schemes, are designed and operationalized? So in this study, for example, many women knew there were camps, but they just couldn't get that 1 hour, 2 hours off from their drudgery of work to go and stand in the line and get themselves enrolled. So they just let it go. So many of the unpaid care work becomes a barrier to seeking treatment, seeking access to healthcare insurance schemes. So next slide, please. And often we use the only framework we use to analyze any UHC is that cube framework of WHO, right? The magic cube, the depth, breadth, and we cannot do an equity-based analysis with that framework. I'm sorry to say, it was a great framework that came at that time, but we have not. Yesterday I saw a paper which has used that UHC cube framework, and that's it. So where do we have gender coming in, intersectionality coming in? We need more robust frameworks to do gender, to have a look at equity impact of universal health coverage schemes. So this is 3 years data from the administration. First of all, in my state, which covers like millions of people, there was no gender disaggregated data because they only had households. You were saying about it, households enrolled. So I couldn't do a gender analysis from the big project data that we kept. But now they have. And if you see the utilization of the health insurance scheme, you will find it's 35%. Women benefited percentage share is just 35%. And of all the resources allocated in this scheme, again, 2/3 went to the men. So in terms of value, in terms of the money that went, was 2/3 went to men. But here we are talking equal hospitalization rate for men and women. So where are women then going? I mean, where are they financing it from? And if you see, the utilization is peaked between 30 to 54 ages alone. And if you see the 70 plus, where actually the lifespan of women is higher and the sex ratio is tilted towards women, the utilization there is more stark and more skewed towards men. So what does this speak about? And why is this pattern? So those are the kind of questions that research by health economists could take it up. And later we find out that 30 to 54, 77% is hysterectomies. Were they all necessary? Because the health insurance scheme is also routed through the private providers. And in India, private healthcare is not regulated. We do not have standard guidelines and standards of care. So therefore, what is advised as hysterectomy as necessary for one woman might be actually very different from why it is suggested to another woman. And then this information asymmetry is so great that a poor uneducated woman from a rural area cannot question her doctor. Is it really necessary for me? What are my other options? Can I think about it and come back later? No, this kind of conversations do not happen out there. But then she has a card and she needs to go back to work and she's been having irregular bleeding. So it becomes a sort of win-win case that you get your uterus removed. But are these really rational? And is this kind of utilization that we are celebrating? So when utilization goes up, we only see it as a positive indicator. But behind that, is the utilization really informed decision-making, transformative decision-making by women or not? Those are the crucial questions to answer. Next, please. Therefore comes, I am in fact not very comfortable with the word unintended. It's not by accident. Sometimes it feels like by design. Sometimes it's a pervasive effect, something that maybe the frameworks has put in, that we are not able to resist. So hysterectomy right from 2009 in India has been coming out in papers as, spiking here in Chhattisgarh and spiking there in Bilaspur. But still 2019 Economic Times says the Pradhan Mantri Jana Arogya Yojana is still reporting a high incidence of hysterectomy. So where are we missing to shake the people up there? And look at this. So the Supreme Court of India in April 2023 says every hysterectomy done in a private or a public health setup has to be reported. Yes, but who's monitoring that? But by reporting, we are not going to bring it down. So the problem with the PFHIS, the publicly funded health insurance scheme in Tamil Nadu, is that it's a market-based insurance model. Therefore, the same language that is there in the Mediclaim policies that the rest of the citizens there takes just gets imposed into the publicly funded health insurance scheme. And therefore, this model does not look at many of the sexual and reproductive health complaints because simply they are not high cost random events. So that is the definition insurance uses to give a coverage or not. So as long as it is not random, then there is a problem. And it also has to be high cost. So the chronic ones get missed out. And the definition of a family in the insurance policy is very heteronormative. It talks about a legal spouse. It talks about employed people after the age of 25 in a typical Mediclaim policy terms. And therefore, this family of many women who are deserted, who come out of violence in their homes, are unable to join the insurance scheme because of these kind of very blind language used, insurance language used in the welfare policy too. And I think I already touched upon hysterectomies, and the kind of information asymmetry that's happening is immense. So for a surgery of 30,000, the provider says, this is not insured, this is not in our package, you go to some other hospital. Whereas it is included simply because the profit margin is not much to make from the insurance scheme. The women are denied and asked to come back later, and they have to pay cash in advance because the private providers do not trust the government to reimburse on time. So what they say is you pay up your money. When I get it back from the government, you come back and take it from me, or you wait till it comes. So these are the kind of dynamics that happen in the field, which makes women not trust this scheme at all. So they deliberately don't use it unless it's a very planned kind of a surgery. It's not emergency. So often they do not trust these schemes. And the last point I would like to really stress is the fact that this financing model has come into the public health system too. What has happened is the neoliberal ideology of pitching both the public and the private in the same footing has made the public providers also now generate revenue through the insurance model. So earlier, when all poor were seen as poor patients, now as a provider, I like the poor insured patients who have a surgery which is covered under the insurance. So I give priority to those people because I can generate some revenue from it for my hospital, the public hospital, compared to the poor who are not insured because they don't have the family card. They're living on the streets. They cannot provide the document. They're too held up with their bread and butter everyday living that they cannot stand in the queue and get an enrollment card. So the patients who are not insured and visiting the public hospitals are now discriminated against. So this this is actually weakening the public health system on which thousands and thousands of people depend from the lower caste, from the rural areas and tribal areas who cannot afford to go to the private health sector. So as a model in itself, it is not towards equity and definitely not towards gender equity. Like the poor woman in the table whom I spoke about, many women prefer the public health setup rather than the private health setup for certain conditions. And by actually then weakening the public health system, such kind of insurance models are actually going against UHC. And unless we recognize these patterns, then we are in the name of increased utilization, increased coverage, 5 lakhs sum covered for each head. You know, those are very glamorous ways of putting the scheme, but on the ground, I came across a woman who lost her life because she was 35 years old with a cardiovascular complaint, which took a long time to diagnose. And then she didn't have a card and she was asked to go and get herself enrolled into the public hospital so that she can use that card within the public hospital. And by that time, her condition had aggravated and she had lost her life. So these are very hard realities that, and I see that these have to reflect in what we advocate and what kind of policy changes that we want to see. Next, I think that's the next slide. Okay. One is to recognize that SRH has to be an explicit focus. It cannot be an add-on later. It cannot come by in the sides, but an explicit focus on SRH, and it cannot be negotiated as something that is low cost and therefore we cannot cover in insurance. It doesn't really lead to high-end expenditures. So the typical insurance language cannot apply for SRH conditions. And one has to recognize the political economic aspects without contextualizing this with what's happening in your country, with financing, who's funding, and what are they funding for, and what is their agenda. Then we are not going to really see the true picture. And I think it's very important for health economists to report unintended effects, anything that catches their eye in spite of what you're actually focusing on to measure. And it's important to understand and capture whether the interventions are changing the decision-making powers. Without that, then it is just a very superficial level of gender change that the policy is bringing in. And I would like you to look at the GRASS framework and also Kabir's social relations framework, because there the market as a factor, as one institution, really captures a lot of things that could be happening in your own country context. Next slide, please. So this is a framework I try to put after my work. So from a lack of financial protection and access to healthcare, moving towards access and financial protection involves identifying gender-specific, gender-intensified, and gender-imposed barriers. This means by gender-intensified, therefore, we are also including men. Information asymmetry doesn't affect only women. It also affects men. Maybe the hernia operations on men is going up because they are not able to also negotiate and find out if these are rational surgeries. So when we are saying gender intensified, then we are bringing both men and women into the picture. And then we look at the household, the community, the market, and the state, and all these factors actually impacting whether gender equity is incorporated within the financial protection schemes. You could look up this framework in the paper published in BMC Public Health on why is women's utilization of insurance low in Tamil Nadu. And don't want to take much time here. And I think the next slide, I think Velosh is coming back again, right? Next slide, please. Yeah. Thank you.
Thanks, Raj. I think Raj. Yes. I think everybody's warm now in the room after that. So nothing much more to add. I think Raji's has really captured it really well. I think she's reminded us again about the importance of information asymmetry. That's something as health economists, we know that 101, the importance of, and in exactly the question around that. And obviously this is also very much gender sensitive. Question around who understands, who has access to information. Some of our work on universal health benefit packages is question around is who's also at the table in terms of priority setting. We know health technology assessment processes. WHO did a survey of countries, I think 2 years ago, of the health technology assessment process. And what was found was that much of these processes is a very technocratic process, doesn't include civil society, doesn't include the beneficiaries in any way. So who's at the table is extremely important in terms of who makes the decisions of what's in and out. I'm not going to go over these slides too much. The last one, much of it Raji has captured, but one of the important things, again, is the question around disaggregated data. But as Asha mentioned earlier, that's only the tip of the iceberg. We need to, if we want change, we need to look at gender-powered relations and how that can happen. Also, I think also just to remind ourselves again, is we're looking at advocating for more resources, but how do we use the resources in a way that can also support change? So for in sexual reproductive health, questions around privacy is important, confidentiality is extremely important, safe spaces. What is the role of provider payment mechanisms and purchasing in that? So we're almost at the end. We know that we've taken extra time, but I think everybody's still in the room. So we have a request. We will do the slide, we'll do our last evaluation now. But if those of you are keen to stay on for our final session we'll break into 3 groups on health financing, health workforce, and sexual and reproductive health to think about some of the research questions, then please stay. Otherwise, after we do the evaluation, then you may leave. So is that okay with you? But we would like you to stay. Yes, but if you do have, yes, before we do that, maybe questions from the floor. Yeah, okay. So if anybody still has some energy, I think you do. Some questions? Yes.
So referring, hi, I'm Helene König from Germany. Referring to the disaggregation of data by gender, especially regarding minorities like non-binary gender, where we directly have a sample size problem, right? Because we're talking about minorities. I think that we have to like gather and somehow not aggregate, but somehow append or get together different data sets from different countries, although I know there's a big heterogeneity because we are like different countries, different cultures, different health systems, but I think only that way we can get enough number of people to have actually and to be able to research and present results for such minorities. And I wanted to ask, do you know of any movements that go in this direction of collaboration and such?
My name is Orokia Sori. I am assistant research at RESAT. I would like to ask my question in French. If possible. Ok, voilà. Donc, je lisais un rapport de l'OMS qui disait de façon globale dans le gender, le gender et égalité du genre, il faut les pays d'Afrique du Sud, les pays sud de l'Afrique subsaharienne doivent mettre 102 ans environ pour pouvoir atteindre l'égalité de genre dans tous les domaines de développement. Okay.
So
no, c'est pas une question.
Yeah, but I need to translate otherwise I would forget.
That's fine.
So she was reading a report from the WHO, and in this report was a report about gender inequalities, right? And so in the report, it was said that sub-Saharan African countries need to would need 102 years to kind of reduce the gap in terms of gender equality in comparison to what higher income countries or okay.
Voilà. Maintenant, ça m'a ramené au système de santé et je me suis dit le système de santé est regroupé aux principaux niveaux. Je veux parler du niveau central, et régional et périphérique.
Okay.
Et j'ai essayé de ramener ça à notre système de santé du Burkina spécifiquement.
Oui.
J'ai essayé de voir quel est le nombre de femmes leaders qui occupent des postes de direction à chaque niveau.
Okay.
J'ai pris le niveau central, j'ai
Uh-huh.
vu qu'il y avait 24 postes de
Okay.
direction et dans les 24 postes de direction, il y avait 11 femmes et 12 hommes et 13 hommes.
Okay.
J'ai pris au niveau régional où on a 13 régions. J'ai vu qu'il y avait 3 femmes et DRS, directrices de trucs régionales de la santé sur 10 et les 10 autres étaient des hommes.
Okay.
Au niveau district sanitaire, il y avait 9 femmes sur 70.
Okay, so she mapped the number, she counted the number of women for the leadership position at the central, regional, and local municipal levels. And in general, it was largely dominated by males, right? Even more, as you go down, it was, yeah. Okay.
Donc, je me suis dit, vu que la lutte pour l'égalité des gens,
so the gap is so huge, I
voilà,
guess, yeah.
ça va prendre beaucoup de temps.
It will
Ça veut
take
dire que
longer.
les pays vont aller de façon progressive. Donc, je me suis demandé à quel niveau du système de santé faut-il s'attaquer
Okay,
pour
so at
pouvoir,
which level of the health system we should target
voilà,
the
pour
action.
pouvoir vraiment avoir l'impact même du genre sur le système de façon globale. C'est ça ma
So at
question.
which level, central, regional, or
Voilà.
local?
Et comme j'ai la chance d'avoir les éminents professeurs ici, je me suis dit que voilà, elles pourront nous éclairer par rapport à ça.
Okay.
Merci.
She wants some insights on that.
Hi, I'm Liana Waski. My doctoral work focuses on coercive sterilization care. So I was very interested to hear your presentation. And one concern that I have that I would actually love your perspective on was, given I think maybe many of the volume-based metrics that are used to track gender equality, like financing, care coverage, access to services, given the prevalence of coercion, particularly in reproductive care, how do we sort of negotiate those two things? And what is the WHO doing now to ensure that issues of coercion, particularly around permanent reproductive care, are sort of baked into those coverage metrics or accounted for? Or I guess don't get sort of swept under the aggregate measures.
Okay, thank you. That's a good one. And any other questions?
I just had a quick one in terms of the sources of the data for, I think, your first item, where you had really disaggregated data. So what we said that it generally in a household survey, we don't have this level of disaggregation. So I wondered which type of survey. Was it a survey that was conducted on purpose for the purpose of the study, or did you use some routine data?
Hi, I'm Surya from India. I was just hooked on and curious about one statement that you made about how most of the time women, when they approach for some treatment, are turned away because of the profit margin for the private hospitals are way lower. Were you able to look at how many times, I mean, for whatever reasons they are turned away in general, how much of them come from SRH? Because from my experience, I thought it's more of a general thing that, you know, it's difficult to get the insurance scheme approved at hospitals. So now I'm curious if it's more an SRH area.
Thank you. So we can take some of those questions. But just want some, I can take some.
Yeah. I'll just go from the easiest or direct straightforward question. So the sources for the maternity, non-maternity, or the CHE disaggregation? Oh, I can show my slides little later than, sorry, which one?
I think it's the one where you had the widow.
How that? Okay, that was from the survey that I did in the rural and urban areas. The catastrophic health expenditure.
But you did the data collection yourself.
Yes, yes. I did the data collection around a house-to-house listing of around 5,000 households, both in the urban and the rural together.
Okay.
Yeah. And then in-depth interviews for those who were hospitalized in the last 1 year, and then asking them details about their health expenditure patterns. So that
And
was,
the previous one,
that is from the National Sample Survey of India, 71st round. That was not from my study. That was not from my study. But I did the disaggregation of maternity and non-maternity and got it. Yeah. Yeah. And okay, to your question on the denials being more from the SRH, I don't think so. In fact, it is not necessarily SRH because the insurance package itself doesn't cover much of the abortions and infertility treatments, though most of it is hysterectomy, where providers are more willing or welcoming rather than, denying. But what I understood about how insurance is not integrating SRH is in the fact that non-cancerous cyst, for example, only the higher end cancerous diseases are included in the packages. So when, for example, in the case studies that I've collected in interviews, there were quite a few women who had SRH conditions, but not so severe for very high hospitalization expenditures. And in fact, one of them was turned away from a public hospital because her cyst is benign and not cancerous, because they want more insurance cases. They want to perform more of surgeries on insured women and insured conditions and treatments rather than the other ones. So it's causing a different kind of a denial there in public hospitals. But I did not find a specific pattern for SRH conditions alone being denied. It's just that the margins as such are very low for SRH conditions within the insurance package, right? So that is the reason why they're not covered under. So the interviews with insurance people, when I conducted, was that we cover something that cannot be expected, which comes in a big way. It has to really be a high expenditure for it to be covered under an insurance package. So an abortion, for example, one of the insurance head said that it's something that is planned, that is in the control of women, and therefore it cannot come under typical insurance principles. So this is how, if you use a market model, this is the problem. I think the insurance for the below poverty line people, marginalized sections have to be designed in a very different way, not with a market-based commercial insurance kind of design. So that's the problem in this kind of a. I don't noted down the other.
I think there was one question about coercion as well. Yeah. I think that's an extremely important area. I mean, we know that, for example, for maternal health and maternal mortality, one of the big focus has been on getting women in terms of increasing institutional deliveries. But what we've seen across many contexts is that has not necessarily made a huge dent on the health outcomes. And one of the questions around that is that, the health systems challenges have not necessarily been addressed. There's quality of care issues, etc. And the question on coercion is another, it's part kind of tied to some of those issues. You raised the issue now of commercialization. That's now become an increasingly recognized area as the commercialization of health, or the commercial determinants around health. So much more focus now. I mean, of course, there's not necessarily that much of research, but certainly it's an area that's getting more attention, is around what are the commercial drivers. One is around public sector, private sector, incentives, both financial and non-incentives as well. I think what we'll do now is we'll just go to if you can go to the Slido, if everybody's been able to log on, if you can do the evaluation, and we'll do our last interactive session for those who will stay on.